Good morning. Works. Well, on behalf of Lupus LA, I would like to welcome you all who are here with us in person, as well as those who are on Zoom, to our 2026 Latest on Lupus Patient Conference. Thanks for coming. For those of you who may not know me, my name is Maggie Sepkowitz, and I am the Virtual Care Coordinator for Lupus LA. And I provide direct patient services that include our emergency grant program, medical referrals, and other community resources. Just let me know if I'm talking too fast. Before we get started and before I introduce our first speaker, I'd like to just go through what's in your folders that you received when you checked in this morning. For those joining us online, there should be a link to the same information. You will find bios of all of our guest speakers today. You will also find an index card to write questions down for our Q&A. And you will also find information about our new initiative, A Roadmap to Lupus. This will be an interactive tool that is designed to help lupus patients within the first 90 days of diagnosis. Our goal is to offer invaluable resources to patients who are going to try to navigate very complex systems, whether it be health insurance, finding the right medical providers, and accessing community resources. In the back of the room in the lobby, you will find a QR code as well as a physical copy of the survey. And we need your help. And we're asking you to please complete the survey because your feedback will impact the direct work that we're all doing. And for anyone and everyone who fills out the survey, you will automatically be entered to win one of 3 $50 Amazon gift cards. And winners will be announced at a later date. For those who are here in person, you also received a blue raffle ticket. So hold on to those because at the close of today's conference, we're going to pick 3 winning tickets. Each winning ticket will receive a $50 Amazon gift card. Okay, and you do need to be physically here to receive the card. So without further ado, I'm going to introduce our first speaker, Lupus LA co-founder and emeritus board member, Dr. Wallace, who will be speaking on the emergent biomarkers of SLE.
All right. It's a pleasure to be here. And what I'm going to do is show the slides that I did when I was asked to give UCLA rheumatology grand rounds 2 weeks ago. So I'm using the same slides because these developments are relevant to everybody in this room. There's about 40 people here, and we're going to get more coming. And we have about 200 people who have signed up to watch us online, and it will stream to probably thousands. But I'm going to talk about the emergent biomarkers in lupus, and I'm going to do it in about 20 minutes because I want to spend the rest of the time, another half hour, answering your questions because in previous engagements, that's what people like to do the most is ask me questions. So you were all diagnosed with lupus on the basis of blood tests. ANAs are 89% sensitive for lupus, but they're only 50% specific. ANAs are seen in a lot of autoimmune diseases. They're seen in lupus, they're seen in Sjogren's, they're seen in scleroderma, they're seen in myositis. They're seen in 14% of healthy people in low titers. The new ACR-EULAR criteria for lupus has upped the titers so that you have to have at least a 1 to 80 ANA to have lupus, not 1 to 40 or 1 to 20. ANAs were described in the 1950s along with anti-DNA. Anti-DNA is only seen in a third of all lupus patients, but it's 97% specific. The person who first described anti-DNA in 1957 was a man named George Frio. I don't know if anybody remembers him, but he did it while at Yale, and then he was recruited, and he was chairman of rheumatology at USC when I was a medical student there in the 70s. And then he went on to start the first rheumatology department at UC Irvine when it formed. Complements came out of WashU in St. Louis in the 1950s as well, and complements were a measure. Anti-SM is named after a patient named Smith, who was the first whose sera was used for that in New York. And even though it's only seen in 14% of lupus patients, it's 99% specific. However, many people who have these biomarkers, these conventional lupus tests, it's not very helpful for lupus, as I'm going to show you for a minute. And some of the tests that I'm going to talk about are on the right side of the screen. So this is a very, very important paper, and this was a game changer. Wes Reeves, who is still the chairman of rheumatology at the University of Florida in Gainesville, was designated 20 years ago as being a center of excellence by the National Institute of Health. And over a period of 5 years or 10 years, he had 263 patients referred to him. And he worked them up thoroughly. And what he found was shocking. 76 of the patients who were ANA positive and referred to him as a lupus patient to the Center of Excellence turned out not only not to have lupus, but had no autoimmune disease at all. And 39 were incorrectly treated, and some of them were put on steroids in doses as high as 60 milligrams a day. This is really scary. Well, it's okay for non-rheumatologists to make a mistake, and half the discordant diagnosis at referrals was seen by non-rheumatologists. But shockingly, 27% of the people referred to Wes's center were rheumatologists, and it turned out that they did not have lupus. So we're not getting it right, as it says, are we getting it right? And for about 10, 15 years after this paper was published, nothing was done. But all of a sudden in the last 5, 7, 8 years, there's been a revolution in new tests that if you might want to talk to your doctor about getting it done. So complement, which many of you have heard of, is done as a C3 and C4, but it's very misleading. Complement activation plays a very important role in inflammation. It's responsible for clearing foreign and damaged materials from the body, and people with lupus experience complement activation. However, there are some problems with the way we measure complement. For example, 10% of people with lupus have almost no complement due to a genetic insufficiency, like C2 deficiency is seen in up to 10% of lupus patients. And then we have people with liver or kidney disease, and they can't make complement. And also, sometimes increases in complement are, some people have a high complement because they're inflamed. So C3 and C4, while it's useful generally if it's low, has a very limited diagnostic utility. But what we've known for a long time was that when we activate complement, complement splits and breaks away into different components. So like C3 and C4, which is what's usually measured, becomes C4A or C4B. And as a result of this, we have these little flecks of complement floating around, percolating through our bloodstream that measure past complement activation. So some of you have had Exogen or Avise testing. This is a lab in San Diego County that looks for complement activation products on the surface of E, or erythrocyte or red blood cells, and B cells. And complement activation products are now being measured not only by that lab, but by other labs. And what we see is a activation cascade that is consistent with lupus. So whereas C4 provides a snapshot of complement activation, it's more accurate than C3. C4D provides a longitudinal timeline. In other words, a red cell only lives 120 days. So if you have EC4D, that means you've had active lupus in the last 120 days, which is often very useful. And following EC4D levels is often used now by doctors like a SED-rate or CRP, but it's very lupus specific. So I'm not going to go into a lot of this right now, other than to say that activation of complement by looking at these complement fragments or pieces that bind to cells are markers of activity and are more reliable than C3 or C4. And it doesn't rule out lupus, but if you have it, you have lupus, especially the EC4D. And if you combine EC4D with BC4D, the chances are 66% specific. And if you look at lupus, rheumatoid arthritis, Sjogren's syndrome, scleroderma myositis, and others, you find that this improves the sensitivity and specificity of lupus. So if you have anti-DNA and anti-Smith and EC4D and BC4D, they add a 25% value to determining whether or not you really have an autoimmune disease. So this is something that can be done by your rheumatologist if they have access to one of the labs that does this. In fact, complement activation has become so important that Al Kim's lab at WashU in St. Louis is looking at 30 different complement components or breakdown products to try to figure out which the best one are, and we will very soon have very, very good tests for this. So this just reiterates this. So I'm going to go on to the next part, and this correlates with a high diagnostic yield with Selena SLEDAI, which is a major score of lupus activity. So complement activation correlates with lupus activity. Okay, also in addition to EC4D, which is on erythrocytes, and BC4D, which is on B cells, in the last few years, Michelle Petrie at Johns Hopkins, who many of us regard as the smartest lupus person in the country, have discovered something called PC4D, which is when the complement components are on platelets. Now, many of you have had anti-cardiolipin or anti-phospholipid antibodies, which is associated with blood clotting. But most people with anti-phospholipid antibodies have never had a blood clot. And that often confusing. Should I take baby aspirin? Do I need on a blood thinner? But PC4D is 99% specific for lupus procoagulant. And these are the people, as you can see, who will have a if you have this, you have a high chance of having a blood clot. So these are the people that should be treated. So this is another advance in complement metabolism. So we have EC4D, BC4D, and now PC4D. Also, there has been a whole group of labs that are looking at T-cell antibodies. Exogen, for example, includes it in their panel, and Quest and LabCorp can now do this upon request. So the point being is that if you have T-cell antibodies, this is very, very lupus specific, because if you have T-cell antibodies floating in your serum, it's a sign that you really do have lupus. So these T-cell biomarkers have superior sensitivity to conventional ones, and as you can see, compared to C3, C4, anti-Smith or anti-DNA, the presence of these biomarkers is much more sensitive and specific. So elevation of this is, as you can see, patients with pure fibromyalgia without lupus do not have complement activation. And I'm going to go on here. Another new blood test that's come out that has revolutionized rheumatology is the availability of hydroxychloroquine or Plaquenil blood levels. Used to be that ophthalmologists told us that you needed to be on 5 milligrams per kilo of hydroxychloroquine. And if you were on too much, they would lower the dose. That's no longer the case. It turns out that Plaquenil, when it's metabolized, is metabolized into 5 different components. So it's broken down to 5 different products. And depending on your race and gender, tells us the metabolism rate. For example, Native Americans have one product that is in the majority, whereas Caucasians and African Americans may have other products which are consistent with this. So measuring hydroxychloroquine whole blood levels tells us the following. First of all, if the number is 0, it means you're not taking it and you're lying to your doctor and they can tell you. Number 2, if it's very, very low, it just means you're taking it occasionally. If it's very, very high, you're overdosing on it and you have a high risk of eye damage. And hydroxychloroquine blood levels between 800 and 1200, for example, are very good at assessing the risk for a disease flare. And we can often, if one has certain breakdown products of hydroxychloroquine that are, being measured in a certain way, that may mean that we need to raise or lower the dose. And there have now been several studies, and there are now multiple labs that do hydroxychloroquine blood levels. So increased hydroxychloroquine exposure is associated with decreased disease activity. We want to be between 750 and 1200. If you're 1284, as in this slide, you're super therapeutic and you need to lower the dose. So the 5 milligrams per kilo dosing of Plaquenil is no longer valid, and what we need to do is measure hydroxychloroquine blood levels, and on the basis of that, we can inform what your dose should be. Okay, so there are many things that are confused with lupus. There's a variety of infections, Epstein-Barr, cytomegalovirus, HIV, parvovirus, for example, can turn on lupus, be associated with lupus, or mimic lupus because they can create a positive ANA. Early malignancies, especially lymphoma, MS, myasthenia gravis, can do the same thing. And a variety of other autoimmune diseases are also associated with lupus. So that's why when we get a positive ANA as a screen from your primary care doctor, we need to look for infection, look for a malignancy or hematologic disorder, and look for an immune disorder. So this is a paper I did with Stuart Silverman, who many of you know, who's a rheumatologist at Cedars-Sinai, who specializes in fibromyalgia. And this, what we did was we took a group of patients in my practice with lupus, a group of patients in his practice with fibromyalgia, and measured complement activation. And we found that those with pure fibromyalgia with lupus, not a single one had any complement activation. So this is an extremely useful test, and it's much more specific and sensitive than the ANA. Okay, so one of the major things that confuses lupus patients is, do they have rheumatoid arthritis? Or do they have something called rupus, which is rheumatoid with lupus? Or do they just have rheumatoid arthritis and they've been treated for lupus? This is very important because if you have pure rheumatoid arthritis, you're likely to be given Enbrel or Humira or one of the anti-TNFs, and those drugs are contraindicated in lupus and can flare it. Similarly, there's a whole host of other rheumatoid drugs, such as abatacept, which have no place in lupus treatment. So there are a lot, Quest and LabCorp and Exogen are working on a whole bunch of extended panels where they look for certain other markers. Because rheumatoid factor, which is the main test seen in rheumatoid arthritis, is only positive in 60 to 70% of RA patients. So historically, we've had a lot of seronegative rheumatoid patients, and we haven't really known what to do with it. The evolution of anti-CCP has improved that to about 75%, but still 25% of rheumatoid patients don't have any antibody markers until now. Now we have something called PAD4, which is sensitive in 14% of seronegative patients and can identify rheumatoid arthritis. They also can identify a rupus or lupus and rheumatoid overlap. So you would want to give, let's say, Benlysta, which is a drug just for lupus, doesn't do much for rheumatoid. So you may want to use a specific rheumatoid drug, such, Rituxan, for example, works for both. So it informs us into the decision-making process. Another one is anti-RA33. RA33 is an antibody that picks up 16% of rheumatoid factor negative patients. And anti-CARP is a very good antibody for early lupus, early RA. It's present in the serum of rheumatoid patients for up to 5 years before the patient has any symptoms or is diagnosed. The CAR-P was originally discovered out of USC by Frank Kismorio 20 years ago, and it was who was 90 and still working in the lupus clinics. But anyway, Frank's work was ignored for a long time, and now everybody's all excited about it because we can treat early disease, because a lot of people have normal exams. They have no joint swelling. And if they have a CAR-P antibody, we can tell that when they tell you they're aching, that it really does mean something, and early intervention is extremely important. Another disease that overlaps with lupus is Sjogren's disease. It's no longer called Sjogren's syndrome. It's called Sjogren's disease, and I don't want to get into the politics of that, other than to say that dry eyes, dry mouth with arthritis is seen in 30% of lupus patients and 30% of rheumatoid patients. So there's primary and secondary Sjogren's. But there are a whole host of now new Sjogren's tests. It used to be just SSA and SSB, which are Sjogren's syndrome A and Sjogren's syndrome B. There's now something called the early Sjogren's panel, which consists of antibodies to the salivary glands, antibodies to the parotid glands, antibodies to carbonic anhydrase. And these markers are often useful in diagnosing Sjogren's with lupus, for example. There is a drug called ianalumab, which was given fast-track FDA designation last week as the first Sjogren's drug since 1998. So we will be seeing new Sjogren's drugs. So if you have a lot of dry eyes and dry mouth and you're not on antihistamines or other drugs that would be associated with this, sometimes this is a marker. It's offered by LabCorp and Quest, and it's often very helpful. Sometimes it overreads, but a lot of people, including myself, do use it. And then there's a whole group of people that rather than their joints, they have issues in their muscles. And they tell you they have muscle aching. And myositis, or autoimmune disease of the muscles, substantially overlaps with other autoimmune conditions such as lupus. A CPK, or muscle enzyme, above 500 is something that we really need to look at. Often these patients have Raynaud's, they have specific skin rash, they have interstitial lung disease. Some of these patients are on statins for high cholesterol and have certain myopathies. And now there's a whole panel of myositis panels that can be done at community hospitals and Quest and LabCorp, for example, and the universities, that helps us determine whether or not you have an autoimmune disease of the muscle. So I'm going to conclude by saying that compared to 10 years ago, we have better tests for lupus, we have better tests for looking at activity, we have better tests for distinguishing lupus from other autoimmune conditions or coexisting with other autoimmune conditions. This is a very exciting area that's going to make it so that your doctor does not give you the wrong drug. So well, I'm going to stop there, and what I think I'm going to do is, you all have 3x5 cards. Let's take 3-4 minutes and have everybody fill them out, and then I will spend the rest of the time answering them, and then if we have time, we will go to the people who are watching us on Zoom. Thank you.
If anybody already has some cards, I'm happy to collect.
What I'll do is I'll put my chair over here. Absolutely. What? Can you all hear me without the microphone? Yeah.
No. We need it for the online people.
Yeah, we can use this one.
Okay. We will start. How do we make these biomarker blood tests more affordable for lupus patients? Well, if you are Medicare or Medicaid, they're paid for. If you have private insurance, it's usually paid for. It's people who have out-of-pocket issues that sometimes these panels are billed at $2,000 or $3,000. But there are efforts now to put these in panels so that they will be affordable. Am I seeing new patients? Do I see patients virtually if they're out of state? Specifically, I have a clinic at Cedars, and I have a private practice in the Cedars area. I am taking new autoimmune patients. It's been a problem to see out-of-state patients historically, and what malpractice carriers have done is that if I see a patient, if I write a prescription to an Arizona or Nevada pharmacy, my malpractice insurance does not cover me. Cedars-Sinai, for example, will not allow telemedicine visits with people outside California. This is a major problem. If you do pay extra for your malpractice, we can do that, but it's often not worth it. The problem in Arizona and Nevada specifically is that they have grown to a tremendous extent without having new rheumatologists. And so in Las Vegas, it's 9 to 12 months to see a rheumatologist. Tucson had the medical school in Arizona. Phoenix is just starting a medical school. They have osteopathic schools. So seeing out of patients virtually can be a problem in that you're not covered for it. And it makes absolutely no sense. If you have a patient with positive ANA but no other markers for lupus, how frequently should you be retested? Well, that's the whole point. If you have a positive ANA but no other markers, you do these markers first. And about 3/4 of the time, you can pick up something. Therefore, sometimes I do a bone scan because what I'm looking for is inflammation. And a bone scan will show me if the patient is inflamed. Not a bone density, but a bone scan. But 14% of the United States has a positive ANA, and only 10% of them have an autoimmune disease. So that's why a good rheumatologist is important. What are the drugs that are good for purple hands and feet when the weather is cold, and how do you treat them? Well, that's called Raynaud's phenomenon. It's named after Maurice Raynaud, who described it in France in the 1870s. And he always said that people with Raynaud's were patriotic because their fingers turned red, white, and blue. Those are the colors of the tricolor of France. So, but anyway, what are the drugs we use? We use calcium channel blockers, such as nifedipine or amlodipine. We use Viagra-related drugs, such as sildenafil. We can use nitroglycerin as a topical, as a paste. And so those are the drugs that are used for Raynaud's. Why does lupus affect African Americans more than other races? Well, 1/3 of all lupus in the United States is African American, 1/3 of all lupus patients. And it is genetic. There's theories that an FC receptor in the spleen that blocks the clearance of immune complexes is altered. It's genetically more present in African Americans. But there are other races that have high prevalences of lupus, certain Native Americans, the Maoris in New Zealand. There are other groups that have it at the same rate as African Americans. But there are a lot of genetic theories. Okay. Do I think that the SLEDAI or BILAG will evolve to include common lupus symptoms that are currently not counted, such as dry eyes, dry mouth, nausea, dysautonomia? Well, SLEDAI is the Systemic Lupus Erythematosus Disease Activity Index, and BILAG is the British Isles Lupus Assessment Group. And these are not used in the clinical practice of lupus, They're only used in clinical trials. So there are efforts to include, there's something called a PRO, or physician-reported outcomes, which are more important and subjective and that are not included in the SLEAD-I or the BILAG. And now there are efforts and initiatives such as PROMISE, which are looking for those. Why do lupus patients experience migraines, insomnia, loss of balance, and dizziness that the neurologist can't explain? Well, there's three parts of the nervous system. There's the central nervous system, which is the brain and spinal cord. There's the peripheral nervous system, which allows you to move your arms and legs and feel things. And there's the autonomic nervous system, which controls your pulse and blood pressure. In controlling your pulse and blood pressure, it does so by opening and closing vessels. So if you go from dilation to constriction, you get Raynaud's, which is the fingers turning different colors. But you can also get Raynaud's in different parts of the body. You can get a migraine for Raynaud's of the brain, where when you get a lot of dilation, you get a headache. When you get a lot of constriction, you get a lupus fog. You can get a chest pain from this as well, which is associated with coronary artery spasm, which gives you sort of an angina. So there's a condition called POTS, P-O-T-S, when you have low blood pressure, paroxysmal orthostatic tachycardia syndrome. And these really are not neurologic disease, they're more in the vascular tree, and dysautonomia is seen in 10 to 20% of all lupus patients, and there's a whole set of separate non-anti-inflammatory drugs that are used. If a doctor has prescribed us on a dosage of hydroxychloroquine based on our race and weight, does that mean we should be taking that dose? And do all doctors have access to the hydroxychloroquine blood tests? Quest, LabCorp, and Exogen all do that. Everybody has access to Quest and LabCorp. The dose of hydroxychloroquine at 5 mg per kilo is no longer valid. Is there a link between lupus and fibromyalgia? Does everybody with lupus have fibromyalgia? Well, fibromyalgia is not a disease, it's a syndrome. It means I touch you, you hurt. And the link between lupus and fibromyalgia is about 30% of people with lupus also have fibromyalgia. And fibromyalgia is usually related to stress. Inflammation can cause fibromyalgia. Just anxiety and not being able to cope with the constant pain and stressors that you're undergoing, it is associated with it. There are a group of fibromyalgia drugs. There are 3 approved by the FDA. There was a 4th that was just approved a couple months ago. Why do these other diseases go hand in hand with lupus? Should we be tested for them by our providers? Well, there's a lot of overlap syndrome. There's something called undifferentiated connective tissue disease, where you don't meet criteria, but you have, let's say, Raynaud's or dry eyes with ANA. There are people who have mixed connective tissue disease. There are people who have something called overlap syndrome. So all these disorders are related. What are the newer Sjogren's tests called other than the SSA and SSB? It's called the Early Sjogren's Panel, and it's available from Quest and LabCorp. It's a biotech company in Buffalo, New York called IMCO, which has licensed Quest and LabCorp to do these tests. What does a patient with lupus need to see a neurologist for numbness and tingling of the extremities and feet? Well, you could have peripheral neuropathy. You could have a dysautonomia. It could be related to certain medications are associated with it, so your doctor needs to sort that out. Did you say that lupus is genetic only in African Americans or hereditary or all people? No. Dave Horowitz, when he was chief of rheumatology at USC about 20 years ago, did a fascinating study where he took a group of identical twin sisters in their 20s and followed them for 10 years and ascertained whether the identical twins developed lupus or not. The answer was 25% did. So lupus is only 25% genetic. A lot of it is environmental. There are hereditary components, but it's not just African Americans, it's everybody. What are the chances that my daughter or son will get lupus versus other autoimmune? If you are a lupus patient, your daughter has about a 10 to 15% chance of getting lupus, about a 20% chance of getting any other autoimmune disease. Most common would be Hashimoto's thyroiditis. If your son would only have about a 2 to 5% chance, since 90% with lupus are females. Is Meniere's disease an autoimmune condition? Yes, it's dizziness, and it probably is autoimmune. Sometimes there's a test called anti-HSP70 that can be done to try to sort it out, but it's not associated with lupus. But 20% of people with one autoimmune disease have a second autoimmune disease. Is SLE related to Good syndrome? It's not Good syndrome, it's Goodpasture syndrome. And Goodpasture syndrome is a kidney disease where you also cough up blood. And lupus is not related to it, but it's a very serious autoimmune disorder. What can we do to get rid of joint pain? Pregabalin and NSAIDs don't work. So why do you have joint pain? Is it because you're inflamed? Is it because there's a mechanical deformity, something structural? Is it that you have crystals? Is it you have an infection? Is that, you have a clot? There's many reasons, so you need different types of imaging, and it may be that there are other reasons why you're doing this. So how's our timing doing?
We have some time.
Okay, so we have about 10 minutes.
A couple more. Yeah, I have a couple.
Oh, we're getting a few more cards?
Yeah, I have a couple more coming.
A lot more cards.
Thank you. Hold on.
Should other treatment options be considered for lupus patients with perimenopausal symptoms? Patients with perimenopausal symptoms can generally take hormones. The amount of estrogen in a estrogen replacement therapy is only 20% of what's in a birth control pill. So it's generally quite safe. Progesterone is safe. Estrogen should be minimized, however, if you have a blood clotting disorder or migraines. There are some other medications that are used for perimenopause symptoms, such as some of the tricyclics that with or without lupus are present. Can lupus patients with CNS lupus and strokes take Benlysta? Well, if insurance will not pay for CNS lupus in isolation, and the reason is that it's never been studied. However, many patients who are given Benlysta also have central nervous system involvement, and they do just fine. So the labeling is just because it's not studied, and the reason why it's not studied is you can't do an MRI every week or every month and a spinal tap every week and every month. So it's very difficult to do this. Are splinter hemorrhages associated with non-infective endocarditis in lupus? Should patients with splinter, bacterial endocarditis is associated with infections, but it is part of an infection, or it's a reaction to a microbe. But patients with lupus, with Raynaud's, can get splinter hemorrhages, which are little red dots in the tips of the fingers if there's not enough oxygen getting to the skin. So you would treat it the same way you treat Raynaud's. What environmental factors cause lupus? Well, the main one is sun exposure. Certain industrial agents can do it, such as polyvinyl chloride, silica dust, and there are tobacco. Cigarette smoking is associated with lupus. So there's a variety of chemicals, and there's also 75 drugs that cause lupus. Does lupus cause a decrease in T and B cells? Yes, it can. It's very nonspecific, but it can. Is low ferritin and iron saturation related to lupus if menstrual cycles are not heavy and the testing is normal? Well, you can have inflammation can suppress the bone marrow, so it doesn't make enough iron. It also, if you have heavy periods, of course, you can have issues. And if you're on certain diets, you may not absorb iron. Iron is probably one of the major causes of fatigue in lupus patients, not due to lupus, but associated statistically with it. Can a lupus patient with minimal symptoms stay without prednisone? Yes. Prednisone promotes fibrosis, which is scarring, which increases the damage index and shorten the life expectancy. How good can it be to take only hydroxychloroquine, alendronate, and methotrexate? Well, alendronate's not a lupus drug. It's not for inflammations to help put calcium in the bones. Methotrexate is a very useful lupus patient medicine, and it's also a good rheumatoid drug. The majority of my patients are not on steroids. Can you describe the relationship between lupus and hematologic malignancies? How often should lupus patients get tested, especially if there's antiphospholipid antibody? Well, lupus per se is really not associated with malignancies, but for those with lupus and Sjogren's, that is associated with lymphoma with a prevalence of 12%. And we screen them with serum protein electrophoreses and other every 6 months. Antiphospholipid syndrome is not associated with malignancies. So do we want to take you want to raise your hand? And
Any other questions? We can bring around a mic.
She'll bring the mic to you.
Could you just repeat the 12% for lymphoma for those with lupus and...
excuse me.
Sjogren's?
Repeat what?
You said there's a 12% chance of lymphoma with lupus?
12% prevalence of lymphoma in all Sjogren's patients.
Sjogren's only or Sjogren's with lupus?
Both.
Okay.
Anyone else?
Any other questions from the audience? Okay, we've answered most of the...
Yes, thank you so much.
Anybody online to do it, or we're out of time?
We answered all the online questions.
Okay,
Yes.
great. Well,
Awesome.
thank you very
so
much.
much. We're going to have a few minutes before our next speaker joins us, so feel free to grab some more coffee or some food. Also, it's an opportunity maybe to complete our survey about a roadmap to lupus. There's a physical copy in your folder, as well as the QR codes in the lobby. So we just have about 5 or 10 more minutes before our next speaker joins us. Thanks.
I have to jump into the caption.
Okay, we're going to come on back and get started. Thank you. Hope you enjoyed your little break. So I would like to introduce Dr. Leanna Wise, and she is one of our Lupus LA Medical Advisory Board members, and she's going to be speaking on reproductive health in lupus, best practices for all ages, and then we'll have a Q&A after as well. Thank you.
Great. So excited to be here. Thank you, Lupus LA, for having me, and to all the attendees, very excited to see everyone here. And just before we get started, I'm talking about reproductive health today, and this is a huge, huge topic. First and foremost, we could have an entire conference on this. We could have an entire week-long conference going into the details. And even despite that, some of the data here is not well researched. Am I speaking slowly enough? Okay, go. So I just like to say that because sometimes there are questions, even my patients ask me, likely people will be asking here in the audience, that some of the questions I can answer easily, some that are... Okay, sure, you're saying I'm too fast now. Okay. I speak fast. So all that being said, in a 45-minute talk, I'm going to do my best to sum things up and hopefully make this relevant for everyone listening, but we are all coming from different life stages, different backgrounds, different walks with lupus. So again, give me a little grace, but I think there's going to be a lot of helpful information here. So with that, let's go ahead and get started. These are my disclosures. So our objectives for today, we're going to understand key reproductive health issues and how to address them for the people living with lupus. We'll talk about some key issues related to medications for people with lupus who are thinking about pregnancy. And we'll also talk about individualized, thorough reproductive health conversations and how to have these early and frequently. And I gave this talk last year, and it focused mostly on contraception and pregnancy, but I realized that there are many other issues not related to contraception and pregnancy, so I've tried to expand that for this year's talk. Just a little bit of a disclaimer again, data on reproductive health in lupus is relatively limited, and it comes out only from a select group of patients that have been looked at and researched. So again, we're trying to best expand that into the rheumatology clinic and how we can discuss that with each individual patient. I don't think for anyone in this room, I am actually your physician. So this is general knowledge, and I want you to bring this up to your specific physician in general, whether it's your rheumatologist, primary care doctor, or your OB-GYN, okay? So this is meant to be informational and for patient empowerment purposes. This is not giving me specific medical advice just to you, okay? So keep that in mind. And again, kind of that third point there, discuss this with your rheumatologist before you make any medication changes. So if something here says, oh my gosh, I need to stop my medication X, Y, or Z, please talk with your rheumatologist before you do that. Why do we care about reproductive health and lupus? Why does this matter? Before we even get into what reproductive health is, I also, again, want to acknowledge this is a very, very broad topic. This is not just for women. We think of lupus as kind of a female disease, but that is only partially true. Yes, it tends to be sort of 90% female, but we know many men have lupus. So this is relevant for both men and women with lupus, but also for their partners as well, because reproductive health ends up affecting the patient's partner. This spans everything from birth control use, sexual health, pregnancy planning, getting pregnant, care during pregnancy, the postpartum period, breastfeeding, preserving fertility. Maybe somebody doesn't want to get pregnant right now, but they do in the future, and they want to know how to make sure that is optimized when it's time. Hormone replacement, maybe they're perimenopausal and they want to know, hey, can I take hormone replacement? Is that safe? And then how does lupus, just from a global perspective, affect all of this and the medications as well? And then we have to condense that into a 20-minute visit where we have other things to talk about too. So this is a big ask of the patient and the doctor. This is a big deal, right? And we're talking about a disease that primarily affects women of childbearing age as well. And when it does affect men, they often tend to be also potentially men who want to start families. So again, as I mentioned there, primarily affecting women of childbearing age, roughly between the ages of 15 to 45. Yes, it can go younger and older, and men as well. I want to acknowledge that there. But when we think about the classic patient and the age at which they're diagnosed with lupus, these are classically the years in which a woman wants to start a family or does not want to start a family, okay? And eventually they're going to go through perimenopause or menopause and have other questions as well. Some lupus medications, as well as active lupus, can be problematic for a baby and getting pregnant. Certain birth control can be problematic for certain types of patients with lupus, and then some aspects of lupus can also complicate pregnancy and the perimenopausal period. So these are all just very relevant questions. This isn't just like, oh yeah, I'll put this on the back burner. For the vast majority of women, we need to think about these questions, and so does the rheumatologist. So again, just kind of thinking of overview, we talk a lot about disease activity in the clinic. It sort of takes the spotlight. It's the first thing, we say, how do you feel today? How's everything going? Any updates from your last clinic visit? And usually how the actual lupus is, from what we know in the literature, even some of the research that I have done, lupus disease activity, it's like the first, second, and third issue that's talked about. And the reproductive health issues kind of take maybe, not always the back burner, but maybe the middle burner and sometimes the back burner, and the conversations don't happen as quickly and as frequently as they should. And then sometimes because of the active lupus, patients might delay having a family until later in their life. Maybe, rather than having a family at 23, 25 as they originally planned, maybe it's going to be 35, and that's a little bit later, and that also has to be discussed. And then finally, even though lupus does have a higher incidence and prevalence in patients of non-Caucasian background, these patients are not actually well represented in reproductive health literature. So we have to also consider having better studies that also include these patients. So in 2020, in the research world, we came out with guidelines for looking at reproductive health in lupus and other rheumatic diseases. This is the first and only guideline that has come out, which is kind of sad. I mean, 2020 is not that long ago, and it is still not been fully updated yet. So we only have one iteration, and I think our European friends, I believe they only have one guideline as well. So there's kind of a lot of work to be done, but at least we have a guideline. Prior to 2020, it was all what was just considered like expert opinion. This big researcher on the East Coast says this, but another researcher kind of says that. And so you kind of just chose whatever sounded the best, and whoever had the most authority at the point sort of had the say in how patients were managed. And now we at least have a guideline to sort of help us move forward when we address reproductive health issues. So I am going to be referencing some of the data from these guidelines. These are free online. If it doesn't look like it's free, just Google it a little more and you should be able to find a free link. This is not something you should pay for through an institution or a school. This is free. There is some medical lingo in it, but some of it is pretty straightforward, and you can always bring this up to your doctor if you have questions about like, hey, what about this? I know I have antiphospholipid syndrome. Can you explain this part to me? This is free and you can access this. And there's also patient versions here and there on different websites too. So I'm going to go over the ACR guidelines and some really key points here. 1, lupus can affect the type of birth control that is recommended for women with lupus. There's certain types of lupus medications we have to think about when a person wants to explore pregnancy. There's particular lupus blood work or complications we have to be aware of that might require extra monitoring during pregnancy. And then for those who are now considered to be perimenopausal, or menopausal, we also have to explore hormone replacement very carefully. And I'm also going to discuss some et cetera issues as well. So let's go through these a little bit. In terms of birth control that is recommended for patients with lupus, it all comes down to 2 major concepts here, which I have on the screen. If somebody has antiphospholipid testing or extremely active uncontrolled lupus, those are the 2 big things on which this hinges. So if a patient comes in and they say, I really don't want to get pregnant right now, this is not for me, maybe my disease is active, I'm in school, whatever it is, you should be asking your doctor, do I have some of these blood tests for something called antiphospholipid syndrome? Antiphospholipid is exactly what you should be asking the doctor, and the doctor should hopefully know this. Or do I have very active uncontrolled lupus, like really rip-roaring, hopefully not, but really rip-roaring lupus? And there are very specific types of birth control you should avoid. And essentially, these are birth controls that are these unfortunately are birth controls that are quite common. The pill, a lot of women take the pill to prevent pregnancy. But what we're concerned about here is extra estrogen in the system, potentially exacerbating lupus, or in this case, blood clots. Both of these have been a little bit debated over time, but to be extra, extra safe and to avoid any complications from these two, this is what the guidelines say, is to avoid these types of birth control. Now, on the flip side, what is recommended is the IUD, which is the little T-shaped device that women can have an OB-GYN place in their uterus. And this is extremely effective and is recommended for lupus patients. And also the mini pill, which is a type of oral contraceptive, but it's not the combined contraceptive. For me personally, I recommend the IUD to my patients because you don't have to think about it. The mini pill requires really, really careful taking. You have to take it like at the exact time every single day without fail. Otherwise, you could get pregnant. So I do recommend, if patients are open to it, to take the IUD. Some older literature, or not older literature, some experts used to think, could it predispose immunosuppressed patients to an infection? There's no evidence that it does. It seems to be very, very safe. So we do recommend IUDs a lot for our lupus patients. But again, if you have antiphospholipid or uncontrolled lupus, please be aware to just at least bring this up to your doctor. I don't think it should necessarily fall into your hands to memorize these, but you should bring it up to your doctor. Hey, does this affect the type of birth control I should use? So again, my takeaway, at least be open with your rheumatologist. Tell them, yes, I do or do not want to become pregnant. Is it safe? And if it's not safe, if it's not time, what should I be using for contraception? Moving on to medications. When we think about medications for exploring pregnancy, so let's say the time is right, you'd like to get pregnant in the next 6 months or 1 year, your doctor has said your lupus is quiet or very close to quiet. How do we approach the medication issue? Because some are considered very safe, some are considered kind of neutral or unclear. There's not a lot of data, and it may actually be okay to continue, but we're not quite certain. And then some are very clearly dangerous. So that's how we sort of group them: very safe, neutral, or unclear, and then dangerous. Before I move on to these medications, though, I like to give, again, a kind of a bird's eye view about lupus and pregnancy. In general, lupus pregnancies are considered high risk. However, most lupus pregnancies actually turn out fine. But there are slightly higher rates of miscarriage, preterm labor, smaller babies, and high blood pressure in pregnancy. But these rates, or these problems, even in the general population, are very low. But they're a little bit higher in lupus, okay? They're not 100%, they're not even 50%, but they are a little bit higher than the general population. And people say, well, what is the chance that I will flare? That's a very common question and very understandable. So this is pretty wide number here, but if I would tell a patient who says, if you have been in remission for at least 6 months prior, there's less than a 1 in 2 chance that you will flare, okay? So let's say you've been really quiet for 6 to 12 months, if not longer. The biggest chance you will flare is about 30%. You may be as low as 7%, okay? So we want patients to be in remission before they get pregnant. However, if they are active at the time of pregnancy, so you have a really bad rash, you had recent fluid buildup in the heart or lungs, potentially 60% chance that you could flare during pregnancy. But interestingly, it's not even 100%, okay? So some people actually get kind of quiet during the pregnancy. So the goal here is, before you get pregnant, please have well-controlled lupus. There's some kind of nitty-gritty data here, but in general, one thing I also like to point out to my patients is even in healthy pregnancies, apart from lupus, miscarriages are common, and birth defects, while they're not common, they still exist. So sometimes I tell my patients, we're going to do everything possible to help this turn out well. And unfortunately, sometimes miscarriages still happen. 15 to 20% of the general population may experience a miscarriage even with a perfectly planned pregnancy, perfectly healthy mom, and birth defects unfortunately do occur in 3 to 5% of the general population. And the reason I tell people this is because I really don't want them to feel horribly guilty or thinking, in retrospect, oh my gosh, what did I do wrong? We did everything right. Did I just do this one thing wrong? Did my doctor do the one thing wrong? Again, up to maybe a fifth of all women have experienced a miscarriage, even when zero chronic disease, doctor has told them everything right, they're a perfectly healthy 25-year-old, whatever. It's very common to experience a miscarriage in the general female population. And again, going back to the first thing I mentioned, the majority of lupus pregnancies are uncomplicated. Yes, they are considered high risk, but if you do things right, we have a very good chance of a good outcome. So before I move back to medications, what can we do to optimize good pregnancy outcomes? Again, control the lupus for at least 6 months prior. Really, the longer the better. I tell my patients 6 months is like the bare minimum. I prefer more like 1 to 2 years. That would be a really nice situation, but 6 months is our bare minimum. This is especially important if you have lupus nephritis or kidney involvement from lupus. Address your other chronic medical problems. If you have really high blood pressure, uncontrolled diabetes, those also have to be controlled. Please show up to all your medical appointments. So if you haven't been going to your doctor's appointments, I can't force anyone to go to a doctor appointment, but it's gonna be a good idea if you're already going to the doctor every 3 months. Once you're pregnant, you will have to go to more appointments, potentially once every 2 weeks or even more frequently at the end of pregnancy. And then of course, be on pregnancy compatible or pregnancy safe medications, which we're gonna talk about. So again, let's go back to those medications and the categories I discussed. So we have some medications here that are considered very safe, and some of these are standards in lupus: hydroxychloroquine or Plaquenil, baby aspirin, which we also start during pregnancy. Some patients will take this outside of pregnancy too, but these are considered super safe in pregnancy and highly recommended per those guidelines I discussed. And then neutral or unclear. And some of this data comes from research that's been done in patients other than lupus. Maybe they have other chronic diseases, other autoimmune diseases, but as far as we can tell, the benefit outweighs the risk. The risk is not zero. However, if it's controlling mom's lupus, if mom's lupus is in remission thanks to this medication, a calcineurin inhibitor, a little bit of steroids, a biologic, it may be safer to continue this to keep mom perfectly quiet at a low dose, hopefully, and we continue through pregnancy on it. As far as we can tell with some of these, there's no high risk of birth defects. Maybe the baby may be a little smaller than normal, but at least we can tell that baby still grows okay, mom is healthy, and that's really what matters for the entirety of pregnancy. And then we have these scary medications down below that we really recommend patients to avoid even prior to conception. So it's not like they're on it and then they conceive and then they stop it immediately. We really want patients to consider stopping them 6 to 12 weeks before conception, some of them even more. Most lupus patients don't take leflunomide, but a few do, and that one would even be longer. So these are things that you'd want to talk about with your physician and make sure, hey, as I'm planning for pregnancy, is there anything I even need to stop or transition to before I get pregnant? And again, this is very patient specific. If somebody's thinking about getting pregnant, I do not want them to stop or start something on their own. This is something that needs to be discussed in depth with their doctor. So as I mentioned, we try to transition patients from dangerous ones to neutral or safe ones. Of course, we don't want to do this last minute, and we want to do this when the disease is under control. We want to control the disease as best as possible and then help patients go on safe meds. And then while patients are on dangerous medications, we actually recommend 2 forms of contraception. So that brings us back to that first point that we talked about. If you're on something like methotrexate or leflunomide or cyclophosphamide, and we say, please do not get pregnant on this, please use effective, safe contraception, and then we should be having the contraception or birth control talk with everyone. So that's, again, why I want to empower patients to say, let's have that conversation. What is safe for me to take? And then we'll talk also about certain things that you'll want to talk to your doctor about if you're thinking about pregnancy, specifically antiphospholipid syndrome, which again is certain blood work that can make you predisposed to blood clotting, miscarriages, or preeclampsia. And you might just require extra blood thinners during pregnancy. And there's also some new studies that show other medications might be very helpful for this as well. But these are not approved yet, but there's some very positive studies going on for this. And again, your doctor will hopefully be checking, but you can also take the initiative and ask your doctor too, have you done the workup for antiphospholipid syndrome or anything that could predispose me to having blood clots? And your OB-GYN can also be looking at this as well. There's also antibodies called SSA and SSB, which can increase the risk of having heart block in the baby, and this can be very dangerous. and the baby may get extra ultrasounds while the baby is growing to look for this heart block too. And similar to the slide I just showed you, there's also new medications in development that could be really helpful for this condition too. There's some older medications we sometimes use to prevent this, but some of new ones that are really, really promising. And again, a good rheumatologist and an OB-GYN should hopefully have checked from this, but you can also ask your doctor too, have you checked me for anything that could affect the baby's heart? And if you do have this, again, be aware you may get extra appointments just to monitor this. And just a few more pregnancy points. As you explore pregnancy or are pregnant, you would be followed very closely by the rheumatologist, OB-GYN, and especially at the end of pregnancy, they're going to follow you very closely to make sure you don't get high blood pressure and something called preeclampsia, which is a very significant complication associated with high blood pressure and kidney problems. And even healthy women can get that too. You're just at more high risk with lupus. For the sake of time, let's go over this slide. Actually, it's important. So I think these are some good questions to ask if you're considering pregnancy to your rheumatologist. Is my lupus controlled enough to get pregnant? And if not, maybe, what can we do next? Is it okay to get pregnant on the medication I'm on? If I do get pregnant, which medications should I continue? And if I'm not okay, if the medications I'm on are not okay, which ones can I switch to? What does this process like? And when can we start? What is the time frame? We kind of already talked about this a little bit, but I also want to point out that last point there is asking about your lupus blood test that could make you at risk for pregnancy complications. And again, that was the antiphospholipid for blood clots and SSA and B for babies' heart problems. And then again, I want to expand this a little bit also to some special situations, which is men with lupus. And some things that the guidelines also point out is if men receive cyclophosphamide, which is an IV chemo, pretty intense regimen that we will give sometimes. We recommend that the men avoid conceiving until they've been off of this for at least 12 weeks. And if it's very urgent that they conceive, if something's happening where, I don't know, I'm trying to think, maybe the woman they have to live apart for some period of time and say, look, we really have to try to conceive soon, you can consider sperm banking. As far as we're aware, there's no evidence that if a man has intercourse after he's been exposed to any medications, that the developing baby and his partner will be exposed to any bad medications or anything, so that's fine. And then there's some minimal data showing that if there's some infertility issues when a man is on sulfasalazine, we may stop the sulfasalazine. This isn't a super common lupus medication, but it's just kind of an FYI. Overall, unfortunately, reproductive health in male lupus is very poorly studied. There's some evidence that some patients with lupus who are male may have higher rates of erectile dysfunction, and there's also higher rates of depression and sexual dysfunction in lupus. But again, male lupus is very understudied, and it's a rich area that we can study further. Let's move on to menopause and lupus. This is a very important topic that is also understudied. I went deep into the literature and tried to, get as much here as I can because my patients actually ask me this a lot. I have patients in their 30s who feel like, hey, I actually think I'm going through early menopause. I don't know if this is my medications. I don't know if I'm just tired. Like, I thankfully have 2 kids now. Maybe I'm just tired from my children. What's going on here? They're trying to figure out what's happening with this. So there is slightly earlier menopause in lupus, but not by decades or so compared to the healthy population. So I actually, off the top of my head, don't remember the numbers, but let's say average age of menopause is about 54 in the general population. In lupus, it's like 52. So it's not a whole decade, but it could be a little bit earlier. And generally, the OB-GYN literature does show that menopause can start on the order of 5 to 10 years before you actually officially hit menopause. So let's say whether it's 54 or 52, it's not unreasonable to have symptoms in your 40s. I think most of my patients who are in their 40s would agree with that too. There's a very slight increase in what's called premature ovarian insufficiency, although the studies are not clear in this. And this basically means your ability to ovulate and get pregnant. But again, the studies are very minimal, very unclear. And this is probably due to the use of a medication called cyclophosphamide in the patients who are in these studies. And we don't use, thankfully, we don't use a lot of cyclophosphamide anymore. This is the really intense IV chemo we used to use back in the day for nephritis. Yes, some patients still do get this, but we just don't use it as much. And again, we're not quite certain if patients have that slightly higher risk of ovarian issues due to that versus other issues. And even it depends on the study that you look at. Now, that second point there, does lupus improve after menopause, is debated. When I was going through my training, one of my teaching attendings or two said, oh yeah, it should improve after menopause. You don't have as much estrogen. This was, the more I actually go into the literature, this is actually not necessarily true. It's more likely related to the length of time since diagnosis. So let's say you're diagnosed when you're 25. By the time you hit 45 or 55, that is 20 or 30 years. The lupus has burnt itself out. It's not really related to, oh, you just have lower estrogen and it's actually the menopause. It's truly just a factor of its time. Now, let's say you were diagnosed when you were 45 or 50. The lupus can be very active. It does not care if you're going through menopause. The lupus can be just as active. And we have seen this in where I work at LA County and Keck. I have seen many patients with lupus diagnosed a little bit later in life, again, 45, 48, and their lupus is rip-roaring. Again, it does not care that the woman is going through menopause. So it's more of a factor, and the literature agrees with this too. The literature, the research has shown that even when you're diagnosed late, you can have very bad lupus. It does not seem to necessarily quiet down with menopause. It only seems to quiet down with time. Once patients kind of creep past that 10-year, 15 or 20-year window, that's when it seems to settle down a little bit. It's not technically a function of menopause. So I hope that makes sense there. And women who do go through menopause with their lupus do very clearly have an increased risk of lupus damage, which is chronic changes from lupus, osteoporosis, cardiovascular disease, and blood clots, even if they did not have blood clots when they were younger. And this is probably due to a lot of different factors, which I have listed here. Chronic use of steroids, potentially some other medications, and then just accumulation of many other diseases, potentially obesity and high blood pressure also contributing. So if you are perimenopausal or menopausal, I would definitely talk with your physician about, how do we actually screen potentially more quickly for osteoporosis, any cardiovascular disease, which includes risk of heart attack, risk of stroke, or risk of vascular disease, say in your legs. And you can be proactive with your physician about this too. So do women with lupus experience more severe menopause is something that has also been brought up by some of my patients. There is like one article, I think kind of 1.5 at best articles that say potentially yes, but this has not been thoroughly researched. In a good research study, there should be a good control group where you have a group of patients without lupus, but is almost identical to the lupus group otherwise. We don't have any good studies with this. So it's a theoretical yes, but they haven't been able to differentiate the menopause symptoms truly from menopause or from the lupus itself. So more research is needed, especially because menopause symptoms can also mimic a mild flare. So I would say I do think some of my patients have more severe symptoms, but I'm not sure. I think I've seen kind of 50-50. So it's a very good question. I wish I had a better answer, but my most confident answer is more research is needed. Let's talk about hormone replacement therapy in perimenopausal women. Will it increase the risk of lupus flare or blood clot risk? So going back to the guidelines. The guidelines are very cautious and guarded about what they say to physicians who want to do this. They're kind of like hands-off. They're kind of like, well, you can consider it only if they have really low lupus disease activity. They don't have antiphospholipid syndrome, so their risk of blood clots is very low. And there's no other contraindications for hormone replacement therapy. And we recommend the lowest dose possible. And we think that it's going to help their quality of life quite a bit. So they're very cautious and very like, yes, I guess you can consider it basically, only if they have the most safest risk profile. And again, they do say in the guidelines, there's just not a lot of data. and you need to weigh the risks and benefits with both the rheumatologist and the doctor prescribing the hormone replacement. Hormone replacement is kind of having a resurrection. It used to have a kind of a bad name, but now it's kind of having a resurrection in the OB-GYN world. So I am a fan of this in the right patient, but again, I do want the lupus to be very well controlled, and I definitely do not want to see antiphospholipid in these patients. So again, this is actually what the guidelines look like when you go through as a physician, a little flow chart. It's I think kind of easiest to find. You're going to assess their antiphospholipid. That's what APL, APS means. Do they have it? Do they just have the labs, or are they fully negative? And green means go, basically. So basically, if they're negative and they have lupus, they kind of cautiously say you can use hormone replacement. If it's non-lupus, but it's still a rheumatic disease, they say, yeah, totally go for it. Okay, so that's how our guidelines kind of look. And if it's a rheumatologist, say, who's not familiar with a lot of lupus patients, maybe they treat mostly gout or osteoporosis only, they can pull up the guidelines and kind of follow the flow sheet and hopefully land on the right answer. And then a few last questions here I do get from my patients as well. Does lupus itself lower fertility? There's no evidence that it does for a patient who's not going through for perimenopause. However, if you did receive cyclophosphamide, that medication itself can, especially if you received it when you were older than 30 years old. And then there's, again, I've already mentioned this a little bit, but if somebody gets an IUD for birth control, which is that T-shaped device you put in the uterus, it's a foreign item. It's a foreign body. It's a little piece of metal. I think some are plastic as well. Could that cause an infection? Because now you have a foreign item in your uterus. There's no data that shows that it would. So do not be concerned if you are immunosuppressed about having this foreign item in your body. I've also had a few patients ask about medication, X, Y, or Z, methotrexate, something concerning, which is teratogenic or dangerous for the baby. Very concerned about, I took this when I was 16, even though I'm 26 now, is it going to stay in my system for a long time? The answer is no. The vast majority of these medications you will purge quite quickly, on the order of 6 to 12 weeks. Some longer, but that's very rare. That's only the medication leflunomide, which that is the sole medication that would be in the system for longer. The last question here, I think, is a very relevant question, which people do ask, and I think is always kind of sitting in the back of the mind of somebody who knows that lupus can be kind of genetic or run in families. If I have lupus, will my child have lupus or another autoimmune disease? We cannot fully predict this. We know that autoimmune diseases do run in families, including lupus or other autoimmune issues. And the studies are not perfectly clear, but even though it may run in families, the risk of having lupus is low, but it is higher than the general population. And the two studies that have looked at this have shown that it is between a 0.2 to 3% chance of having a child with lupus. So it's still low, but it's there. So it's not zero. Nobody can predict. There's no in utero or during pregnancy test they can do. We would not check the baby when he or she is born. This number is technically 4 to 5 times higher than the healthy population. Well, 4 to 5 times higher sounds scary, but when the first number is very low, it actually ends up being only 0.2 to 3% chance, depending on the study. One study showed, again, 0.2% chance. Another study showed a 3% chance. So it might fall somewhere in the middle, maybe a touch higher, maybe a touch lower, but it's not going to be a 50% chance. The study that showed, I think the 3% chance also showed that if somebody has the partner with lupus, or if they have a high SSA or SSB, the chance does go up a little bit. So that's just interesting to know. So finally, as we wrap up here, this is a little bit of our research that we also looked at here. This is also consistent with some of the literature too. We've also found that patients who don't speak English, unfortunately, have less reproductive health conversations with their clinicians. So we encourage patients who don't feel as comfortable with English or have non-English fluency to try to be more proactive, because in order to make up that deficit, that would be important. And then sadly, also, older patients of childbearing age don't get conversations as frequently as they should. So somehow physicians feel like, oh yeah, if the patient's 18 or 22, 24, I need to talk with them about reproductive health. But for some reason, when the patient's like 35 or 38, they think, oh, they're not doing any, they're not having sex anymore, they don't want a kid. And it's like, no, they still need to be, the reproductive health is still important for that age group. That's still technically reproductive health or childbearing age group. They still need those conversations, but for some reason they don't have them with the older patients anymore. Start the conversations early. You guys can help with those conversations. Be proactive, even if the rheumatologist doesn't. Even if the rheumatologist is a male physician, please have the conversations early and ask those questions and be proactive. Contraception, pregnancy, menopause, all of those are relevant to lupus. Involve your partner and your family too. I think these can be a big area of support. Help you remember some information. A lot of information is sometimes given in these clinic visits. Handouts can be given sometimes, or just all that information that you're hearing. Sometimes you just need that extra person. And we try to avoid unplanned pregnancies if possible. If that does happen, there are options. You can always call your rheumatologist and see how to deal with these. Sometimes we do have some tricks, and we can give you some further data about risks in continuing the pregnancy if that's desired. Here's some resources. Lupus Foundation of America has a nice handout on lupus and pregnancy. And then lupuspregnancy.org is from Duke University. This is supported by GSK and has a really nice handout called Hop Step. And this is in English and Spanish. It's a one-page, actually I think one of them might be 2 pages too. Really nice guidelines, not guidelines, sorry, just a nice informational handout about how to look at lupus and pregnancy. And again, these are not menopause related, but it's contraception and pregnancy related. So this is just summing up. We've talked about a lot today. We talked about lupus and medications affecting about how we approach pregnancy, reproductive health in general, contraception, etc. Again, reproductive health is a huge, huge topic, so we really tried to hone in on a few pertinent areas. I tried to be evidence-based and talk about how the guidelines are, kind of our first structure, but we do have a lot of areas in which we don't have evidence, male health in particular, menopause. We really aim for well-controlled disease before somebody gets pregnant. If we have healthy mom, we have the best chance of healthy baby. We absolutely want healthy mom for healthy baby. Menopause is something we can carefully navigate with lupus. More data is needed on that. And again, I really encourage patients to ask your doctor questions. Even if you're not quite sure what your question is, just start to explore. If you're like, hey, I just kind of need more information about pregnancy and lupus. What's my risk? Can you tell me how I would navigate? You don't have to have this perfect, eloquent, well-formed question. Just start the conversation, even if you don't want to get pregnant now. Maybe it's 2 years or 5 years. Just start the conversation. It's better to do it early than to do it when you're like, look, we need to get pregnant in 3 months or else. Have the conversation now. Those are the best ways to prepare and start gathering the information over and over, little by little at different clinic visits. All right, that is it. Can I answer some questions?
Thank you so much. So if anyone has any questions, we'll bring around the mic. Feel free just to raise your hand, and we will bring a... Susan's going to be right behind you.
Hi, yes. I was wondering if you could let us know, how would you recommend navigating a pregnancy with a doula?
I'd be fine with a doula. I would just want the doula to be aware of the diagnosis of lupus and communicate with the OB-GYN and rheumatologist too. I would strongly be against a home birth, but the doula should be in the hospital, a birthing center if the physician is also there. But just given the risk of complications during the birth, I would recommend being in the hospital. But I'm totally fine with a doula being around. Probably would help mom feel more comfortable if she wanted that too. Yeah.
I know that it's very important for your lupus to be stable before you try to get pregnant, but obviously as women get older, you start running out of time. Yeah. So how do you, are there experts on that? I mean, I think it's just hard because you can't put it off forever if you want to carry a child, but lupus is lupus, yes. Right? So I don't know if you have any advice for that, or because there's other risks, obviously, with an older pregnancy, being totally. Older when you do that.
That is a great question. So we want lupus to be as well controlled as possible, but very low disease activity is okay too. So if it's not zero, but it's close to zero, and you're like, look, we kind of need to do this soon. I don't want to be 38, 42, although I have seen successful lupus patients get successful pregnancies at that age. But you're right, we don't want to be pushing into our 40s if we can avoid it. There are certain, and this is where there's some like nuances of talking with the doctor, and hopefully the doctor's aware of this literature, or you'd want to see maybe somebody really specialized in lupus. There's specific labs where you're like, if these labs look good, the chance of the pregnancy being successful and healthy is actually really good. The complement levels being decent, and the platelets being decent, and low to zero protein in the urine, or at least the nephritis or the kidney involvement is not active. So maybe there's a tiny bit of protein, but it was from nephritis that was 5 years ago. And we know that it's not recent nephritis. So if there's still a little bit of rash, still a bit of hair loss, maybe a touch of joint pain, for those do not look like they're associated with bad pregnancy outcomes. And if those are just sort of smoldering, but those labs that I mentioned are fine, the pregnancy maybe actually be okay, and we're kind of okay with proceeding, because you're right, we can't take another 5 years to try to, just put every fire out and get it to zero, when it's like the woman doesn't really have 5 more years. Her eggs are not quite what they used to be at age 20. I agree that is where a good doctor who feels comfortable managing lupus and saying, there's still a little risk, but the risk of getting pregnant at 40 instead is higher than with a little bit of lupus disease activity.
We're going to take one question online. I know, but we'll just trade off. When I was diagnosed with SLE in the late 90s, I had 2 children already, a girl and a boy, and I was told to tie my tubes, of which I did. Is that still the protocol?
No, that's unfortunate, and that's not the first time I've heard that. We have done some qualitative research at USC, and we sadly have had many patients who were told after their diagnosis, no more children, don't do it, you're done. And this does tend to be an older thought process. I would never tell my patients, you're done with pregnancy, don't do it. Now, there may be a few super severe manifestations, incredibly high blood pressure in the lungs called pulmonary hypertension. I can't speak to every individual's case, but that is not standard practice. Yeah.
Hi, I just have a question. So if I'm not planning to get pregnant, but I want to freeze my eggs, but if my lupus is active, can I do that, or I need to be in remission to do that?
You can freeze your eggs with active lupus, but we would prefer that you don't freeze your eggs when on like mycophenolate or one of the teratogenic medications, mycophenolate, methotrexate. But otherwise, as far as we can tell, and again, there's not much data, but it should be okay to freeze eggs with active lupus, but again, without the dangerous medications that I've mentioned. So you'd want to purge off of those for a little bit, freeze the eggs, and then go back on those medications.
Okay, the next online question, how do I know if my symptoms are from lupus or perimenopausal symptoms? I was diagnosed with lupus at 39. I'm now 42.
That's hard. That would probably just take good discretion between you and your rheumatologist. So blood work can be a big component of it, watching how your blood work changes or doesn't change over time. I usually tell my patients, I don't want to look at just a single lab and say, yes, your lupus is active or it's not. I tend to look at blood work and how it changes over time. And then also treat the lupus well and see what happens. Have the right therapies on board. And then if needed, start HRT, hormone replacement therapy, if that's indicated and you're open to it. And there's also a recognition that there's also kind of like type 1 and type 2 lupus symptoms, which is debatable. Type 1 being some really objective active rash, active arthritis, and type 2 being more like brain fog and fatigue, which can be seen in lupus, it can be seen in fibromyalgia, menopause, and this requires more of like a holistic approach, exercise, healthy eating, good sleep patterns. There's no lab test for this. So it depends on what the symptom is exactly, but it does require a good, healthy discussion with the clinician. There's not going to be a perfect lab test unless your lupus labs are way out of control. Yeah, sure, then it's the lupus. But presuming your symptoms are kind of subtle, it's just a conversation with the rheumatologist.
Hi, I'm just curious about preeclampsia. I had that with my first child, with my daughter. But I wasn't diagnosed with lupus until several years later. But then when I told them that I did have the preeclampsia earlier, it helped more with the lupus confirmation.
Yes.
How often does that happen?
It happens actually kind of often, and there are researchers kind of interested in that to see if that does happen, to see if there were people who have no diagnosis of lupus and then they were diagnosed maybe within 2 years after. And when it's kind of hard to do this because they have to be within the same healthcare system so that we can actually see prior pregnancies. But they're diagnosed 2 years after, and they want to see, well, wait a second, if they've had a pregnancy in the 2 years before the diagnosis, what were those pregnancies like? And interestingly, a little bit of this early data shows stories like yours. They had difficult pregnancies at the end because they had preeclampsia or the baby was born too small. And then sadly, other similar stories of they were diagnosed with lupus when they're 30 and they've had 3 miscarriages from antiphospholipid syndrome. So I think it would not be unreasonable if somebody is pretty healthy and they're like, why am I having miscarriages? Why am I having preeclampsia? That should for sure start a workup for lupus. And I know some good OB-GYNs will do that. Yeah. Yes, that should for sure trigger. And we often do see good rheumatologists, good hematologists and OB-GYNs saying, well, I got to do the workup for lupus and antiphospholipid syndrome. And then we see the patient secondarily after that.
Thank you. Okay, another online question. In terms of HRT, are estradiol creams inserted vaginally and estrogen patches with minimal estrogen okay with lupus in remission?
This is a little beyond my scope. I would discuss with the OB-GYN or primary care doctor. Technically, the guidelines say the lowest effective dose. So I would just talk with the person prescribing it saying, technically, it's the lowest effective dose. That's what the guidelines recommend.
Hi, thank you so much for this excellent presentation. My question is about the monoclonal antibody treatments. So Safnello and Benlysta are on your slide considered to be neutral, and then rituximab is considered dangerous. And I wanted to hear, more about why you've classified the monoclonal antibodies in that way.
Yeah, let me even bring that up just so we can reference that. So, oops. Oh. Okay, so this is a good question. I'm glad you also caught this. And I do have this discussion with people who are on either. So anifrolumab and Benlysta or Safnello, anifrolumab, belimumab or Safnello and Benlysta, and then rituximab. So I'm actually going to start with rituximab first. This is an infusion we give through the vein every 6 months, give or take, maybe sometimes every 4 months, but roughly every 6 months. It stays in the system for a very long time. Neither rituximab, nor anifrolumab, nor belimumab, none of those actually cross the placenta and hit the baby in the first trimester. So they actually don't affect the baby's growth or development at all. However, they do absolutely pour into the baby's circulation in the 3rd trimester, and they can immunocompromise the baby when he or she is born. So rituximab stays in mom for so long that it's really hard to time it and dose it for when baby is born. So if you give mom rituximab, let's say at month 4 of pregnancy, and she delivers at 9 months, it's still going to be in the system. It doesn't actually cause birth defects in the same way that methotrexate or mycophenolate does. It's actually not as dangerous as mycophenolate. I guess you could, in theory, kind of put it in between the neutral and dangerous, but it's pretty immunosuppressing, and it has such a long half-life or such a long amount of time in the blood. And that's why we recommend that you don't give it unless you absolutely have to. But it technically does not cross the placenta at all in the 1st trimester, which is the most important trimester for birth to avoid birth defects. After the 1st trimester, baby just grows. That's all he or she does. From 2nd trimester to 3rd trimester, it's mostly just about growth. So then moving on to anifrolumab and belimumab, these similarly do not cross the placenta in 1st or 2nd trimester. So if they're required to control disease, baby does not see these drugs at all through all the 1st trimester. Most of the 2nd trimester, they may trickle in just a tiny bit, but it's a pretty small bit. And again, risk of birth defects is basically gone because the face forms in the 1st trimester, the spinal cord, all these other important parts have formed already. Now it's just about growth. So once these monoclonal antibodies start really pouring in the third trimester, we can actually just stop them in the third trimester and let mom deliver without these in her system, and then actually restart them once the baby's out, because they have a shorter half-life. They're a shorter on and off compared to rituximab that stays in the system for a longer period of time. But neither rituximab, nor anifrolumab, nor belimumab actually cross the placenta in the first trimester, and they don't cause birth defects. So I feel comfortable continuing both of these until about week 28 to 30, and then I stop anifrolumab or belimumab, see how the patient does. And some experts will even continue them all the way through pregnancy. If it's imperative to control mom, and they say, nope, I need you on this. Mom needs to stay quiet. I do not want any lupus. Some experts will continue them all the way through birth and breastfeeding, and they are safe in breastfeeding. Does that answer it? Yeah. Mm-hmm.
Okay, so I think we'll do one more from online. Does age in lupus complicate pregnancy further, as in being in mid-40s?
Yes, I mean, just being in mid-40s complicates. Now you just unfortunately kind of have two complications, the lupus and being what's called advanced maternal age. Anyone over the age of 35 is at risk for other complications. So unfortunately, you do have the two. I have seen healthy pregnancies in a couple early 40s pregnancies, but you just need way more guidance, way more TLC, and you'll probably have a lot of appointments.
Okay, thank you so much.
Great.
Thank you so much.
Thank you, everyone. Thank you.
Okay, I'd like to introduce our next speaker is Dr. Andrew Bitmansour from Fate Therapeutics, one of our sponsors, who will discuss, FT819-10T, an off-the-shelf CAR T-cell therapy for the treatment of lupus. Thank you.
Thank you so much for the organizers and inviting us to give a presentation. As mentioned, I'm from Fate Therapeutics, where we have developed a really interesting and unique paradigm for generating CAR T cells, which, as you all know, are the hot topic these days. And I'll discuss our program with you and how our investigational trials are going. We're located just down the road in San Diego, so we feel local to Lupus LA, so we're happy to be here. Okay. I feel that I don't really need to talk about this because of our two excellent speakers that came before me, but just a reminder, as you all know, what causes lupus. As you all know, lupus is a very systemic, complex disease. There's a lot of factors, as we talked about earlier, that go into contributing to the development and the progression of lupus. Thank you. I've been told to come closer. Genetics. During the Q&A with Dr. Wallace, it was clear that genetics has a clear factor in determining lupus. There's defective immune system environment that can also go into the development of lupus. There's environmental factors that factor in. What I want us to focus on is the B cells, as you're familiar with, related to autoantibodies as one of the prognostic factors for lupus, and how B cells play a pretty key role in the pathogenesis and the progression of lupus. So I became interested in immunology in undergrad, and I continue to study it, and I still learn a lot about immunology. But one of the things that really fascinated me about the immune system is how tightly regulated it is. And in a healthy setting, everything functions perfectly. As shown here in the two circles, we have the two major parts of the immune system: the innate immunity, which is cells that are immediately reactive to infections. They're the kind of the first responders. And then we have the adaptive immunity, and those are the cells that come in later. They're more educated, they're more specific as to how they target the different pathogens that enter the system. B cells, as shown here, are part of the adaptive immunity. And along with T cells and NK cells and so forth, they serve a really specific purpose in maintaining a healthy immune system. But that's a healthy immune system. What are the roles of the B cells? So B cells, in and of themselves, can produce antibodies, which are targeted proteins to selected parts of different viruses and bacteria that can target them and remove them from the system. They can also activate T cells, which are their partners in the adaptive immune system, for activation, and T cells fulfill their purposes specifically by finding the harmful cells and killing them. Also, B cells produce cytokines just like other cells in the immune system, and these are chemicals that help with activation of the immune system once there's an infection that's detected. And as I mentioned, these systems are very tightly regulated in a healthy setting. But in cases like lupus disease, it's unfortunately that it's the dysregulation of the immune system. So what I'm trying to depict by this slide is showing that in lupus, we have hyperactivation, hyperproliferation of B cells that can lead to production of a lot more antibody that's necessary, which in the case of lupus targets double-stranded DNA, and we have ANA and other lupus-related antibodies. It can cause the activation, the proliferation of T cells, way more excessive than need be, of course, through the production of more cytokines, chemicals that contribute to the inflammation of the immune system. So then, as you can see here, I hope I can impress on you, the B cells play a key role in lupus and the dysregulation in lupus disease. So let's bring it back to CAR T cells. CAR T cells were initially studied in different cancers. And here I'm showing you a review of some of the successes that CAR T cells had in different cancer studies and a couple of the CAR T cell drugs that have been approved for the treatment of cancer. These specific CAR T cells targeted B cells, and targeted B cells because they were T cells that were had a molecule on them that targeted a specific protein on B cells called CD19. So when these CAR T cells were made, they could only attack and remove B cells, so which is very specific, and therefore it reduced their safety effects and increased their efficacy because they were specific towards the CD19 B cells, and they showed to be very effective, and they continue to do so. So naturally, a few years back, and around in 2020, 2022, a group of rheumatologists in Germany thought about, okay, in cancer, we have the successful treatment of B cell mediated cancers. We know that B cells play a key role in lupus. Why can't we use the CAR T cell technology and apply to lupus? And that's exactly what they did. And they were able to successfully show that using anti-CD19 CAR T cells for the treatment of lupus, they were able to get amazing results. Their first study, which came out in around 2022, studied 5 patients. These patients had lupus, had been diagnosed with lupus for a long time, had been treated with multiple therapeutics, and were refractory. So they had moderate to severe lupus. They gave them a single dose of the CD19 CAR T cells after a period of chemo to reduce the number of cells that allowed the CAR T cells to implant. And amazingly, they observed remission in all 5 patients after 3 months. They continued to monitor the patients through time, and the patients were actually able to reduce and even discontinue all their therapies, and therefore they were drug-free for 8 months. So this was after only single injection of CAR T cells. This group has continued to study cells, and this report was just published last month, showing their continued study. Now they're up to 10 lupus patients that have also incorporated other autoimmune diseases, which, by the way, are also B-cell mediated. So the CAR T-cell application would be really beneficial for these. They've shown a pretty good safety profile, which I'll talk to about in a few slides. In their lupus patients, they saw remission in 9 out of 10 patients out of 6 months. I think the one patient that did not meet the marks of being in remission is because she had lupus for so long. She had pretty severe kidney disease, and so that kind of disqualified her from being considered in remission. But all 10 patients were on stable immunosuppression and steroid-free, and other patients too, and the myositis and scleroderma had the same effect. So these were incredible results that had not been seen until CAR T cells came onto the scene. So I've talked about CAR T cells. Let's just do a reminder of what CAR T cells are. As I showed you, we have the human immune system is a collection of many different types of cells. We talked about B cells. Oops, let me go back. Talked about B cells. They're specified to kill pathogenic cells by, once they come in contact with them, they can secrete lethal chemicals and therefore destroying those, the pathogenic cells. B cells, we talked about how they can produce antibodies that can target cells. So with the idea of CAR T cells was to take the best parts of a T cell, combine it with the best part of a T cell, and come up with a super chimeric antigen receptor T cell. And that essentially is shown in this figure. This is the antibody that's from the B cell. It targets CD19, and it's engineered onto a T cell. So the CAR T product is a T cell that has this antibody that can find and destroy only CD19 positive B cells. So with that said, let me share with you what we're doing as far as our investigations in autoimmune diseases with our CAR T cells. We have a unique platform that makes CAR T cell infusion and delivery really simple. And the reason I say that is because, as I mentioned to you, the studies from Germany, they use autologous CAR T cells, which means the patients that were selected to be in that study, their blood cells were removed, they were taken into the lab, their T cells were isolated, and the antibody was engineered onto the T cell to generate the CAR T cell, and those cells were expanded to sufficient numbers in order to be effective, and they were reinfused back into the patient. This process of developing these autologous CAR T cells takes quite a while. It takes 2 to 4 weeks while the patient is waiting. Our unique platform at Fate Therapeutics bypasses this whole process of waiting. Our cells are pre-made. Because of our unique platform, we've generated a really homogeneous, stable population of cells that are ready to be infused. So in our studies, in our trials, once a patient is selected and enrolled in a trial, the cells are ready and then can be infused immediately. So the patient does not have to undergo the leukapheresis process for isolating their cells. There's no processing and waiting for that. Our cells are available on demand, and that's where the term off the shelf applies to, because they're literally ready once the patient is ready to be infused. And because the cells are pre-made, we continue to examine them for their function, for their viability. So our homogeneous population is very effective and very viable to do the job that they're supposed to do. So what does it take to be in the study steps for our particular trial? As I mentioned earlier, with CAR T cells, sometimes it's necessary to be treated with chemotherapy in order to kind of clear the system, because this is a cell therapy. This is not a monoclonal antibody therapy. So the cells that are infused, the CAR T cells that are infused, need space to expand and to go and find their target cells. So that is done by giving a short course of chemotherapy to kind of clear the system a little bit in order to allow the CAR T cells to implant. Our option is either chemotherapy, but we are also unique, and we're also investigating an option where no chemotherapy is required. So the patient does not get chemo, but instead, if the patient's on a stable dose of background therapy, such as mycophenolate, mofetil, azathioprine, or methotrexate, they can come in, bypass the chemo step, and get the cells. So, as I mentioned, our option with no chemo is continuation of their background therapy, whatever that they've been on prior to entering the trial, or they can get a dose of either cyclophosphamide or bendamustine. These are two chemo agents. Another thing that differentiates us is that we give a lower dose. It's a milder dose of chemotherapy, because we're also trying to investigate how much chemotherapy is actually necessary for the CAR T cells to be functional in autoimmune diseases. And the reason I say that, because a lot of the procedures for CAR T therapy were adopted from cancer studies. So what we're trying to do is trying to modify and optimize them for the treatment of autoimmune diseases, because obviously lupus is very different than cancer. So once the patient comes in with their background pre-treatment, they get their CAR T cells. It's a single dose of CAR T cells. It's a single infusion, takes a couple of hours. Patients are monitored for the next few hours just for safety. We don't require hospitalization, so the patient, once deemed fine by the investigators, can go home. And the follow-ups are, for the first month, we do a weekly follow-up just to ensure the safety, and then it rolls into a monthly follow-up for 3 months, and then every 3 months for up to 2 years. So this is kind of the gist of our clinical trial study. We've been studying these for a couple of years now, so we have some data to share with you. When we first designed our study, it was for lupus, so obviously we have a lot more lupus patients, but we're also examining myositis, ankylosing and scleroderma, which are also other B-cell mediated autoimmune diseases. But what I want to share with you today is what our typical lupus patient looks like that has entered our trial. As you can see here, I'm showing you results from 12 patients that have been enrolled. You can see here there are very typical lupus patients. They're young women, primarily women of childbearing age. They came in with a lupus disease duration, a median of 8 years, anywhere from 1 to 34 years. They'd gone through multiple prior therapies from 3 up to 10, and our follow-up has been a median of 4 months. So we've been able to study them for quite a bit of time. Their lupus disease activity index, which basically measures the severity of a lupus, high numbers meaning more severe disease, low numbers meaning less severe disease, is 14. So anything above numbers SLEDAI of 6 or above is considered severe, moderate to severe. So these patients came in with pretty active disease. More than half of our patients also came in with kidney disease. And a measure of their kidney disease is looking at the protein and creatinine ratio in the urine, which is 2.6, which signifies active kidney disease. PGA is another measure of disease activity, much like lupus disease activity index. And it's a scale of 0 to 3, 3 meaning high. So they came in with pretty high PGA activity. And finally, FACIT fatigue. As you all know, fatigue is a major factor in lupus that can be very debilitating, that may not be captured by some laboratory measures, but we all know it clearly affects lupus patients. There is this score that indicates the level of fatigue, In this case, it's opposite to the others, where low numbers mean high fatigue and high numbers means healthy. And these patients had an average of about 23, meaning that they had a pretty high fatigue score. So before I show you the results, I want to really emphasize fatigue in lupus. As you can see here, this is a really nice review of all the different factors that contribute to development and the progression of fatigue in lupus. We have organ damage that can contribute to fatigue, vitamin D insufficiency, social factors, other diseases. Obviously, depression plays a role in fatigue. Fibromyalgia was talked about earlier, poor sleep quality, a prolonged use of steroids. All of these are really major factors in fatigue. So that's why fatigue is a really, I believe, good marker to examine in lupus patients and to see how efficacious medications are in addressing fatigue along with the other disease activities. Before showing you the results, I want to show you the safety, because safety is the most important thing. A drug cannot be used if it's not safe, no matter how efficacious it is. Fortunately for us, and I believe for CAR T cells across different studies, safety has been pretty good. There are three major factors or safety points to consider with CAR T cells, cell therapy as opposed to monoclonal antibodies or standard steroids. One is called cytokine release syndrome, and I'm sure you're all familiar with this with COVID, which is basically a hyperactivation and the presence of high numbers of cytokines which lead to inflammation. And that is scored from 1 to 4, 1 to 2 being low grade, 3 to 4 being high grade. Another safety signal to watch for in cell therapy is neurotoxicity associated with cells, because cells can traffic into the brain and the nervous system and therefore cause some neurotoxicity. It's also known as ICANS. And in our case, graft versus host disease. So when you implant cells into a recipient, you don't want to have the reaction that can reject the cells. From our studies so far, I'm showing you results from 10 patients. Fortunately, we had only low cases of low-grade cytokine release syndrome, which is basically fever, which is addressed with Tylenol and antipyretics. We had no cases of ICANS and no cases of GVHD, and other cases of side effects, which is infection or low blood counts. Those are mostly attributable to the chemo, which reduces the total number of cells, therefore having a higher risk for developing infections. All of these patients here that are shown continue to be in the study. They resolved their cytokine release syndrome within a couple of days and their other adverse events, and they continue to be in the study and do well. So how effective are our CAR T cells in our lupus patients that we've examined so far? Oops, let me go back. This shows you the measure of this lupus disease activity index. As I mentioned, high numbers indicate more severe disease and low numbers indicate better outcomes. The blue lines show the group of patients that did receive chemotherapy prior to the infusion of our CAR T cells, and the orange indicates patients that did forego their chemotherapy, stayed on their background therapy, and came into the trial and received the CAR T cells. And this is looking over time. The results show that all patients, regardless of which group they were in, responded really effectively and rapidly after receiving the CAR T cells. Within the first 3 months, they were able to reduce their lupus disease activity score and maintain that response over time. We see the same trend with the other disease activity measure, the PGA. Patients in both groups came in with relatively high PGA scores, but they dropped pretty early within the first month, and by 3 months and after, as we continue to monitor them, they maintained the low PGA scores. I mentioned we had patients that came in with kidney disease, and the measure of urinary protein-creatinine ratio is a measure of kidney disease. Once again, high numbers meaning higher kidney disease, and low numbers meaning better outcomes. By the first couple of months, there was some activity here, but then all the patients had a really amazing response to their UPCR and then have maintained low levels throughout our observation period. And finally, FACIT, the measure of fatigue. You can see here it's divided into low scores having severe fatigue and the healthy being within the 30 to 40 range, and then topping off at 52, meaning no fatigue at all. Patients coming in with low FACIT fatigue scores were able to overcome that and have shown to be in the healthy, and some have reported no fatigue throughout the study period. So overall, from the patients that we've studied, we're seeing some remarkable responses, and that they're also durable. A lot of these patients, not all of them, have been able to either discontinue their background prednisone or reduce it to a really low manageable concentration. They do maintain background plaquenil because that's recommended, but they have responded really nicely with very low safety signals to be worried about. So what type of a patient can enroll in our FATE clinical trial? As I mentioned, patients that come in that have severe active lupus, their lupus disease activity must be at least 8, if not higher. Per FDA, we are not allowed to enroll patients with CNS lupus. Those patients that are enrolled are non-responsive to steroids, so they've been treated with either steroids or 1 or 2 biologics and have been either stopped responding or have been just completely refractory. So those patients come in with really fewer options for positive therapies. And finally, as you can imagine, patients that are not pregnant or breastfeeding and are willing to use birth control are the ones that are enrolled in our trial. So there's lots of CAR T-cell studies going on. What are we doing that's different? I hope I was able to impress on you that our cells are uniform. They're all CAR T-cells. They're all functional and viable, and they target CD19 positive B cells. Obviously, our patients don't have to undergo the leukapheresis period because our cells are ready, they're off the shelf, and they're ready for immediate infusion. We don't require stopping their background medication weeks or months in order for them to wash out of the system. Patients can come in and just 5 days before the trial stop their medicines, so there's no gap in their treatment. And I think most importantly, this is a healthcare provider and patient co-decision. So patient sits down, talks to the rheumatologist, or the rheumatologist recommends CAR T cells, and based on their discussions, based on the rheumatologist and the patient's knowledge of their specific background lupus, they decide whether they would like to enroll in our trial or not. And I'll be here, and I have a couple of dedicated colleagues here. After the talk, we can share with you a lot more information if you're interested. But I would also recommend, if you'd like to learn more and inform yourselves more about CAR T-cell trial, please visit our website. There's a lot of really good general information and more information on our clinical trials. So thank you.
Does anyone, any questions for before? Oh, comment?
Thanks for a great presentation.
Sure.
At what point do you expect that the patients that have gone through this will be able to stop the Plaquenil and the prednisone? Because in my opinion, isn't that the whole point?
Yes, so that would be a shared decision between the patient and the rheumatologist. Because as I showed you, weekly and monthly assessments are done. the lupus disease activity measures, the PGA and other scores are shown, and the doctor decides how well the patient is responding and how they can, and usually it starts with a taper. It's not a immediate discontinuation. So we'll start tapering and see how the patient responds. But it's usually by the discretion of primarily the rheumatologist to see how well the patient is responding, because every patient is individual and they're going to have different responses and different times of responses. We do allow continuation of background Plaquenil and prednisone, only up to 10 mg per day. All other immunosuppressants are discontinued, but we do allow that flexibility of continuing background hydroxychloroquine just to make sure that the disease can be controlled very well. But that's through continued examination of the patient. Yeah. But is it expected? It's not expected. It's desired, but it's not a requirement. Yes.
Hi, everyone. Good morning. My name is Luisa Sather. I'm a clinical trial manager over at Fate Therapeutics, and I'm here with the director and study lead, Sahar Roshan. And in your folders, there is a flyer that was included, and this has some information about our clinical trial. There's also a QR code that you can follow to take you over to our website. And if you have any questions about the study or potential participation, at the bottom of the flyer, you see that we have clinicaltrials@fatetherapeutics.com. Please reach out to that email, and we'll be able to get you in contact with a site that is participating in the trial so that we can connect you with the study coordinators and you can begin the conversation about potential participation. As Andrew explained, clinical trials do have rigorous eligibility criteria, so that does not mean that because you attended this talk or you're interested, you may be able to enroll, but there's nothing better than educating ourselves and being our own advocates. So do your own research, go online, check the website, reach out to us if you have any questions, and that way you can learn a little bit more about us. And if it's not you, it could be for your friend, your cousin, your sister, anyone that's around you. As we know, many people are affected by lupus and autoimmune. As Andrew mentioned it, we not only target lupus, we also target myositis, scleroderma, and ANCA vasculitis. So we are not restricted to only lupus patients. We understand this is a lupus specific, but being in the autoimmune disease community, we find other patients as well that are not, or other people that are not just lupus specific. So follow that link, reach out to us. We're more than happy to talk to you, and thank you for having us today.
Thank you so much. Okay. I think we're going to go ahead and break for lunch. Lunch will be from 12:30 to 1:15. There's box lunches in the lobby area. And as well, please take a few minutes to visit our exhibit tables. And of course, the QR code is still there for our survey if you haven't. So we're here, we're around. Any questions, just come and find us. Enjoy your lunch. We'll see you back here at 1:15. Yes, we are bringing back, these are the tables for lunch as well. So I guess we'll all just be back here. Thank you.
Thank you. So yeah,
All right. Hello, everyone. I hope you enjoyed your lunch and conversation. We're going to go ahead and come back in and get started for our afternoon portion. Okay, I have the pleasure to introduce Dr. Zoe Indigo, who will be talking about decoding discoid lupus.
Good afternoon, everyone. Can we hear me okay? I'm Dr. Zoe Indigo. I'm a board-certified dermatologist and the founder of Skintervention. I'll give you time to spell that one. I'm founded in Beverly Hills with another clinic in Inglewood, and I also see patients virtually throughout California. I did my medical school training at Wayne State in my hometown of Detroit. Any fans out there? There we go. There we go. And I did my residency training at UCLA. So I know we're in enemy territory here at USC today. And I want to talk to you today about decoding discoid lupus. So a few goals for today. When we leave here, you are going to know what discoid lupus is. You're going to be able to identify the signs, recognize the triggers, the symptoms, and its complications, and understand its treatment and preventative strategies. You're going to have a tool to advocate for yourself. As a physician, I'll be the first to tell you that medicine is changing, especially in dermatology. You are booked in some cases for a 10-minute appointment, and you're lucky if the physician spends 5 minutes with you. So we know that all too well. That's the reason why I founded Skintervention, because I need more than 5 minutes with you. I want to know you. I want to know your skin inside and out. It's your largest organ in the body, and it deserves that attention. So let's get into it. What is discoid lupus? Discoid lupus, as we know, is an autoimmune condition. It's characterized by these annular, disc-shaped inflammatory papules and plaques, round-shaped. And it most commonly affects the scalp, the ears, the face, basically any sun-exposed area. So in California, that could be any part of your body. The lesions themselves are often asymptomatic, meaning they're not that itchy, they don't really hurt, but they can lead to scarring and pigment changes over time, especially in people of color. Now, as we may know, Black people, especially Black women, are 3 times more likely to be diagnosed with lupus. And the risk of hyperpigmentation is almost unavoidable, especially if not detected early. So I always say, time is skin. We know there's different types of cutaneous lupus erythematosus. That is the overarching umbrella of the term. When you think of lupus, you often think of that butterfly rash. That's one type, the acute lupus. There's also subacute lupus. Subacute lupus, we usually think of that on the arms and legs, commonly described as red, but we know in skin of color that can be violaceous or even slightly more brown. And then there's discoid lupus. Discoid lupus is easy to distinguish between the 3 types because it often has a lot of scaling. It's often these thick plaques, and again, focusing on the face, the scalp, even the ears. But discoid lupus can mimic and look like a lot of other things to the untrained eye. And I don't put this here to scare you, but I do have a question that every patient with lupus should be able to answer. Who's your dermatologist? Because of having lupus, you are at an increased risk for other autoimmune conditions. Psoriasis, eczema, atopic dermatitis. That being said, your skin is more sensitive than most. And what may look like dandruff or seborrheic dermatitis in your average patient, in a patient with lupus, that could be the beginning signs of a discoid lupus, a scarring type of hair loss. And I always tell my patients, time is skin. The medications that lupus patients are often on can make you more susceptible to photosensitivity, which can ultimately lead to skin cancers. Black people don't get skin cancer, right? We've heard that one. But we know that when our immune system is dysregulated, we are at risk for skin cancers that we often would not have even come to our radar. And what could look like psoriasis in your average Joe, when you're dealing with lupus and your immune system, especially is flaring and getting back into sync, could be something much worse. So what does DLE look like? That's the slang term for discoid lupus, DLE. Again, red or violaceous disc-shaped plaques with scale. But honestly, I've seen discoid lupus present early. It can look like acne. It can look like just this rash that won't go away. I was taught during residency, patients don't read textbooks. What does that mean? The condition doesn't have to look exactly like the picture. And again, our goal is to catch it early so that we're not dealing with the scarring and disfiguring effects that discoid lupus can have. One thing about discoid lupus, sort of a clue, is it can change color. So it can start off as this red or violaceous, but it can turn to white or even dark, what we call hypo and hypopigmented presentation. And over time, that can result in scarring. So one question to ask yourself is, do my lesions, do my spots tend to change color as they heal? That's a sign that it's not just a rash and it's not just something to brush off, but it's something to seek attention for and from a dermatologist. So what do patients notice? We already said it's not that painful, it's not that itchy. Another clue to it being discoid lupus is that burning sensation, some tenderness. Why is that? Because there's some activity going on in the dermis of the skin. When we think of the skin, we think of the epidermis, the outside of the skin. But discoid lupus is coming from the inside out. It's an inflammatory process. I explain it to my patients. There's a fire under the skin, and your immune system is starting it. Your T cells, specifically your CD8 toxic T cells, we gave them a good name, didn't we? They're down there starting a party in the dermis, and it's our job to put it out. Why? Because time is skin. When this happens in the hair follicle, it can permanently destroy that hair follicle. I'm sure we've seen photos of lupus affecting the scalp. And it's more than just cosmetic. I know as a dermatologist, it's more than skin deep. So most patients are coming to me once the disease has burnt out or progressed. So my goal is to see you before we get to that point. That being said, if we do get to the point where there is scarring, there's always treatments. Anything from dermal fillers, injectables can help sort of soften. Even Botox can help soften scars because scars are angrier in places that move. So if you are able to freeze that movement, you give that skin a chance to heal. So if anyone needs an excuse to get a little Botox in their forehead, not that we needed much of an excuse. There's a lot of other treatments as well. There's laser treatments, there's injectable options, there are topical prescriptions, even chemical peels have their role in treating discoid lupus. So I say that to say that in my office, we offer these treatments with expertise and also compassion. Let's talk about triggers. Who can guess the #1 trigger for DLE? Stress, I heard. UV. Another one, smoking, that didn't make this list. The number one trigger for discoid lupus is sun exposure. I tell my patients, you have to treat yourself like you're allergic to the sun. That's how on it you have to be. The sun basically is like fuel to that fire that those T cells are activating. That being said, smoking is another big trigger. Smoking tobacco, smoking via vaping, smoking marijuana. I have a number of patients that use marijuana to help because lupus can hurt. With that in mind, there's other ways to ingest the marijuana. So I meet my patients where they're at, especially in California. And it's important to know that even smoking the marijuana can cause that vasoconstriction. That's a fancy word for saying it's decreasing blood flow. If your immune system is trying to put that fire out, because that's what we're all doing, is self-healing, that's what we're trying to do, you've now vasoconstricted and cut off the water supply. What do you think that's going to do to the fire that's burning under the skin? Let's talk about sunscreen. As I said, the number one trigger for discoid lupus is sun exposure. I say this to say that in some cases, if I put my patient in a room like this, their discoid lupus will get better all by itself. Why? Because there's no windows. Even that minimal exposure from getting your mail in the morning to waking up and working on your laptop by the window, that counts as sun exposure. The thing is, there's different types of sunscreen. And I think that, we as a community need to do more education in explaining the two. Most chemical sunscreens, probably some of your favorite chemical sunscreens, are chemical-based sunscreen. They have avobenzone, benzene, some sort of benzo in the label on the back, because sunscreen is a drug, believe it or not. So they've got to label the ingredients. That chemical sunscreen is absorbed into the first couple layers of the epidermis. The epidermis, meaning the outside of the skin. But we just said the fire is happening below. So it's important to have a tinted mineral sunscreen. Mineral sunscreen is going to act like a shield and really cover everything and protect everything underneath it. That's why, especially when we're treating inflammatory conditions, we must have a mineral tinted sunscreen. Now, you've probably tried mineral tinted sunscreens. Those are the ones that notoriously give you that white cast. Well, I proudly formulated a micronized zinc version of that blends on all skin tones with no white cast. I'm very proud of that. And it's important because, again, those melanocytes, those CD toxic 8T cells are brewing, and we need to protect them as well. Chemical sunscreen is just not getting deep enough. The other thing about sunscreen is it only works as often as you use it. How often do you think you should be applying your sunscreen? I heard every 2 hours. I heard every day, at least 3 times a day. Every 15 minutes, that is a lie. Girl, you are covered. 58 minutes, that is specific. The answer is every 2 hours. That is what we recommend. Now, I live in the real world, and that's tough to do. So I like your explanation. Put it on every morning, even if you're not leaving the house. We talked about if you're sitting by a window, you're getting that exposure. I keep it in my car, actually, because sometimes as my whole skincare routine is marinating, I got my vitamin C soaking in, I need to give a little break before I put on my sunscreen. So put it on at lunch. By that first shift of working or sweating, your sunscreen's gone. So you need to reapply it at lunch. I use that kind of as a marker. Over your makeup? Yeah. Over your makeup, absolutely. And when you try my sunscreen, you'll see that it melts into your skin. So over your makeup, because again, we need that protection. And then finally, especially if you're living in California, on your way home from work, our sun is still beaming and shining. I have felt the sun on my skin on the way home. That means it's time to reapply. So whenever you find yourself, this feels so good, where's my sunscreen? That's what I want you to associate it with. So how do I diagnose discoid lupus? Well, I have been training as a board-certified dermatologist, so I could probably spot it from across the room, but it does help to have a detailed history. How long has this been going on? What are your symptoms? And a thorough dermatologic exam. If you go to the dermatologist and they're not offering you a full body skin exam, challenge them. Hi, let's start with a full body skin exam, because just because you don't see it doesn't mean that it's not brewing somewhere else. And then often we confirm that diagnosis with a skin biopsy. One, to make sure, because like I said, it can mimic other things, but also for insurance coverage for your treatment plans. And then I will often get a blood test to rule out any other systemic causes of lupus. One thing about discoid lupus that's a little frustrating is that it can be ANA negative. So just because you've got your ANA and it's negative doesn't rule out discoid lupus. And in fact, most patients are ANA negative when it comes to discoid lupus. How do we treat it? Topical steroids, that's where we start. We are trying to extinguish that party that's happening in the dermis, and nothing shuts down a toxic T cell better than topical steroids. There's also other options like calcineurin inhibitors we've seen today. Some patients I have are worried about steroid overuse or steroid atrophy. But when we're dealing with time is skin and destruction, it's gold standard to stop and shut down the inflammation. Sometimes if the lesion's thick enough, I'll even inject a steroid into the area. We all know as well the antimalarials play their role, Plaquenil, hydrochloroquine. And also there's other heavy hitters. I've had to pull out the big guns like methotrexate and azathioprine to really shut it down systemically and shut that party, stop the fire, and get you into sort of a remission, calm state. That being said, another treatment that's often underutilized is Accutane. Accutane, does anyone know what Accutane is? Yeah. We think of Accutane for the treatment of acne, also known as isotretinoin, but it can be used in its way to sort of exfoliate the skin, and the dryness that it causes can sort of burn out and dry out that inflammation as well, so something to keep in mind. So your job is to monitor your skin. Look for new lesions. Don't just brush off that spot on your arm. Oh, it's not been healing for a while. And it can take months to get into a dermatologist. I'm building my practice, so I could probably get you in the same week. But in general, it can take months. So making sure that you establish care so that if something is brewing, you're seen in time. The other thing is to check your scalp. It's especially tough depending on how you wear your hair. You may not have access to your scalp at all times, but it's important. Check your beards. Feel it underneath that skin because things can be hiding underneath. And I always tell patients to take photos. The moment you feel something's weird, snap a photo. We've all got $1 million camera in our back pocket. And that way, when you do get to your dermatologist, you can show the progression of things over time. And I want to talk about the emotional and social impact that this condition can have. Anytime we have a visible skin condition, it impacts how we show up for ourselves and show up in the world. We have done the studies, and it's very obvious that your skin conditions can affect your overall quality of life. So I encourage my patients to always seek support. There's a lot of blaming when it comes to getting that diagnosis. Why me? I always just say, blame your mama. Mine's watching. But it's really genetics. That and diet and stress, it can all play a role, but you're just susceptible. And it's a lot to digest. So I challenge all my patients whenever I'm the one delivering that diagnosis, give yourself some grace. Be gentle with yourself. Skin conditions, particularly, especially skin lupus with its discoid lupus with its scarring process, can absolutely impact your mental health. We've heard about the patient resources before. I've got a full list here, but one that I think is often underutilized is social media. There are a lot of influencers, content creators who share the good, bad, and the ugly of lupus. And I think just visually seeing someone live their diagnosis out loud can be really reaffirming. There's TikTok. I'm sure you guys already know this. Have you heard of this website called YouTube? But I encourage my patients to reach out and seek those resources because they can be really inspiring and uplifting. And, a lot of times people have their finger on the pulse when it comes to new treatments and things like that. So, managing life itself can be overwhelming, let alone adding on a diagnosis. So, something that I recommend to my patients. Another underutilized one is Reddit. I'm not being compensated by Reddit to say that, but I've noticed that my patients are often looking to Reddit for information and what did this drug do for you? And so, I don't know, it's definitely a resource that you may not have thought of. So for key takeaways, I really want to get your attention because your skin needs your attention. Discoid lupus, it's chronic, it's scarring, it can be subtle, it can start as an ember, and it can rip and roar like a fire. And we are here to help you put it out, to detect it. Early detection can lead to much different outcomes. And prevention's even better. Tinted mineral sunscreen, zinc-based sunscreens that are going to cover the entire epidermis and dermis. Dermatology follow-up is essential, but I'll add that being established with a dermatologist is essential because, again, you don't want the first time you think to call the derm is when the spot shows up. You might be waiting 2 to 6 months depending on where you're located. Luckily, I do virtual appointments. So it's not meant to scare you, but to empower you. Your skin is your largest organ in the body, and it needs your attention. So with that, I want to open the floor up to questions and say thank you.
So if we have our sunscreen on and we're wearing a UPF 50 hat and UPF 50 clothes and all of that good stuff, to what extent do we still have to avoid the sun? Can we get any sun exposure at all?
I think that's a great question, and I think it depends on how active your lupus is. So the question is, if you didn't hear it, does having lupus mean I can't have any sun exposure at all? If you're flaring, absolutely not. Strict sun exposure. So strict that I will write you a letter to the DMV to tell them to tint your windows strict. That little amount of sun exposure is giving those T cells that energy to burn. Now, if you're dormant, if you're outside of a flare, sure, have fun, be responsible. You sound like you're doing everything right. UV, protect clothing, I don't even wear that. So you're doing great. But I say that to say, you know your body, you know when you're flaring, you know when you start to feel that burning and tingling, that's the sign to jump on it and shut it down with very strict photoprotection.
Dr. Zoe, this is online. I had a rash that covered my whole face, but started around the chin area and quickly rose all the way up under my eye lines. On my left lower eyelid, there felt like a sty was coming when the rash came to the eye line. I was prescribed doxycycline, topicals, and antibiotic eye drops. Once the rash got under control, the sty turned into a tumor for ophthalmology to deal with. Are these possibly related?
Well, Possibly, anything's possible. I would say when we are treating with doxycycline, it's given me a sense that your dermatologist likely maybe thought that could be some rosacea. And rosacea can absolutely affect the eye. We call it ocular rosacea. So I won't comment on if your particular example is or related to, because you haven't stepped into my office for my thorough assessment. But with that in mind, yeah, lupus can present and mimic all of those things. I've diagnosed lupus and mom thought it was ringworm, literally last week. So it's important to have a trained dermatologist evaluate you because there's nuances that we can use to get the diagnosis right. And follow-up is also important because, like I said, patients don't read textbooks. So how your rash looks today versus 2 weeks versus a month versus 3 can be different. So I do hope that you are getting the care that you need. Yeah, so if you work indoors, do you have to be careful with sunscreen? The answer is yes. Most likely, if you're working indoors, you're working in front of a laptop, and that laptop has what we call blue light. Your phones also have blue light, and that blue light can activate. We've done the data, we've done the research, and it can activate the dermis. So it's important even still, if you don't leave the house, if you're just in front of a computer, which we all live in front of screens, it's important to have that sunscreen, absolutely. And it's not just for lupus. This goes for any inflammatory condition. If you've heard of melasma, for example, melasma is when you get brown spots on your cheeks, usually the sun-bearing area, so cheeks, foreheads, even mostly cheeks and forehead, around the eyes. Those patients also have to treat themselves like they're allergic to the sun. Just using the cell phone. I saw a patient, they were doing so good with their sun protection, but they were holding their phone. That light and that heat caused their melasma to flare only on one side of their face. So melasma I use as an example because you can see it. You can see immediately the changes that the dermis is going through, whereas in, discoid lupus, it could take a little bit longer. Another trigger, since we're talking about it, is heat. Heat in terms of saunas or heat in terms of working out. Now, I don't say that to say don't work out, but be mindful, maybe using a cool towel just to keep your skin cells calm.
So I have a question. So I went to get a biopsy at UCLA about a year ago. Then biopsy said lichen planopilaris, but it said the differential was discoid lupus. And that's actually what triggered me to go to a rheumatologist, where I did get diagnosed with lupus. Mm-hmm. Is it worth re-examining that biopsy?
Yeah, I think a biopsy gives you a clue. So if we want to get into it, the dermatopathologist is getting one slice of the picture. They probably included the hair and they saw inflammation in those particles. So lichen planopilaris and discoid lupus can both attract those cytotoxic T cells. So I would say the goal of the biopsy is to get to the diagnosis. I don't know that I need to revisit the biopsy because you're already treated, but I would be really mindful of hair loss, especially if that were to continue, because you'd want to make sure you're treating the skin from the inside out and the outside in.
Hi, I have 2 questions. The first one is, say you have someone that's had lupus for a while. How often do you see their changes in skin triggered by hormonal changes? That's number 1. And number 2 would be, what is your recommendation of dermatology visits for someone who is more actively outdoors?
Absolutely. So I would say our hormones can absolutely affect our skin, especially when it comes to inflammatory conditions. One obvious example is acne. That's very cyclical, so those changes can happen every month, whereas in some changes are more gradual, especially as women are entering perimenopause and menopause, that estrogen's slowly declining over time. So it's not uncommon for there to be more of a slow manifestation of the condition. To answer your second question, how often should you be seeing a dermatologist? I say a full body scan once a year is not unreasonable. If you see your dermatologist and they say, you're good, I'll see you in 3 to 5 years, that's fine too. But it all depends on your risk. After the age of 40, living in California, I would say minimum once a year. We have just too much cumulative sun exposure to put us at risk for not only detecting discoid lupus, but also skin cancers and other inflammatory conditions.
Hey, so I wanted to see your recommendation for hair. So I don't know if people are going to put mineral sunscreen on their scalp, by the window or when they're out in the sun, or if people even want to wear a hat while indoors.
Yeah, I understand that. Well, the good thing about the scalp indoors is that your laptop is not directly facing it in the same way that it is your face. But I have diagnosed plenty of women with skin cancers in their scalp, and it is always on that part. So on the hairline part. So I do recommend either you can dab some sunscreen there or you can wear a hat, especially when you are outside. So, I mean, that's kind of what we have to do, especially living in California. There's just so much exposure. Now, you've got great thick hair. I want some of that. Some people aren't as blessed. So especially if you have hair thinning, your scalp is exposed. And if you've seen any older man who has lost all of his hair, you can see the manifestation that scalp is skin too. And you can absolutely have skin cancers there. So I say you have to be mindful. If you can, switch up the part. That's just good practice in general for decreasing hair thinning. And that's the sun protection aspect of it. Now, if you want to take another direction and talk about what we can do for hair thinning and hair loss, there's a number of different options. One is Rogaine, over the counter, available for years, nice and cheap because they lost the patent. You can also start Rogaine. The active ingredient is minoxidil by a pill. So if you especially have healthy kidneys, healthy heart, it's definitely an option. And I've seen patients where their primary care doctor just refuses to handle it. Because again, we're practicing medicine and it can be quite litigious. But if you are informed of the risk and it's something that you want to do, there is a role to safely take oral medicines and treat your hair, especially under the right care and supervision. Other options include injections. I've had a number of women with scarring alopecia. That scarring tissue is like concrete. Now imagine a hair follicle trying to grow through concrete. It's not happening. It's like grass trying to grow through concrete. So there's treatments that I can do in my office to break up that scar tissue. And there's also new developments. PRP. Has anyone heard of PRP? We're in California, so we know what's up when it comes to cosmetic things. PRP is where I take your blood, I spin it around to the good stuff. It's liquid gold. That's PRP. It's basically platelet-rich plasma. We then inject that into the scalp, and it takes all those growth factors, all those nutrients, and just supercharges that area, super concentrates it, and we can get hair to grow back. Another treatment is exosomes. This one's a little bit more cutting edge. You know what's up? Exosomes are what we used to think as the garbage truck of the cell. We now realize it's more like compost. And it's packed again with those growth factors and those energy cells. And you can source exosomes from a lot of different places. You can source it from plants. You can source it from pigs. You can even source it from umbilical cord fluid. So I have in my office, they call it Wharton's jelly because that's just a way sexier term than umbilical cord fluid. But that same fluid and energy was just used to grow a whole baby. It can be used to grow some baby hairs too.
Hi, thank you, Dr. Zoe. Two questions. One is, how about like fluorescent lights? Does that do anything as well? Does it have the same like effect as like UV? And my second question is rosacea. What's the correlation between lupus and ocular rosacea?
Oh, sure. So to answer your first question, fluorescent lights, yes, there is some blue light in the fluorescent light. That being said, it's more ambient and it's scattered as opposed to the screen that is directly on us. And that being said, I mean, there's arsenic in the air. We live in LA, but you can do what you can to protect, what you can. So sure, should we all be walking around with N95s? Absolutely, especially after the fires. I didn't leave my house without it. But then you sort of, get to your new baseline of normal. So it depends on just how vigilant you want to be, and it depends on how much you're flaring. But if you're flaring and you can't get it under control, those are some of the first things I'd cut. Dairy is one of the most pro-inflammatory things that we have. And if I have a patient who's really trying to cut down their acne and their inflammation naturally, it's the first thing I tell them to cut. But what's life without cheese? So it really just depends. It really just depends on how vigilant you want to be. To answer your second question, I don't know the association between for lupus and rosacea. I would imagine that there are a lot of, rosacea is one of the most diagnosed conditions. And I'm certain there's somewhere where someone's being treated for rosacea and it is possibly a subacute type of lupus that is ultimately revealing or going to reveal itself. But the two of them together, I'm not so sure about any association.
Thank you so much, Dr. Indigo, for your excellent talk. I have two questions for you. So the first, how do you distinguish between a rash that's from lupus versus a rash that's from eczema? And the second one is, do you have like a number in mind in terms of the UV that's outside that you would advise your patients with SLE or discoid lupus to sort of, watch out for? Like a given number, then that's the threshold to like stay inside or put on UPF, put on sunscreen.
I'll be honest, I don't monitor the UV. I also don't live with this skin condition, but I would imagine that any bit of sun exposure is going to be triggering. So I would never say leave the house, but I would also say incorporate these safe practices into your routine. And I do it as a dermatologist. I do it more so because I've seen the effects of the sun on photoaging, on wrinkles and scarring and hyperpigmentation. So I don't leave the house without a visor. I was in Disneyland a couple weekends ago. I had my visor on. And when I'm in the car, I wear my sunglasses because, our skin around our eyes are the thinnest, and that's where a lot of people show their age first. So I wouldn't say there's a certain UV index to watch out for, but just watch out for that sun. When you're driving, that arm that's on the window, that should have sunscreen on it. Your first question, remind me? Yeah. So how do you distinguish between eczema and lupus? If a person has both, so you just made it even more complicated. Well, I will reach back into my training and I can hear my attendings' voices and some of the cases I've seen. There are some clues. Atopic dermatitis, especially depending on what age you are, shows up in different parts of the skin. So if you've got your rash kind of like behind the knees or in the folds or, secondary to using a brand new gift from Bath and Body Works, that's leaning towards atopic dermatitis. Whereas lupus, again, loves sun-exposed areas. So if I'm seeing you're clear on your whole body, but your ear is flaring or your face or your neck, my suspicion goes up. I also want to know about your family. Family history plays a big part of my physical and my history and my exam. Other things to look out for is the type of pain. As I said, lupus can sometimes burn and sting. Not to say that atopic dermatitis doesn't, but it does mostly itch. There's blood tests that we have at our resource, and ultimately we can do a biopsy. And not to get into the dermatopathology of it all, I had to learn that so you don't have to. But Lupus is really a dermal process, whereas atopic dermatitis is more epidermal. So sometimes I will do a biopsy. I had a patient, she came in, she's got eczema, it's not getting better. Let's punch it. Let's do a biopsy, take a little piece of skin, numb it up, you don't feel anything, pinch and a burn. Don't feel much. And then let's look at it under the microscope. I actually use USC as my lab, and I have a great relationship with their dermatopathologist, and I'm able to pick up the phone with the dermatopathologist. What did you see? What do you think? Do we see that, what we call lichenoid inflammation, or is it more superficial or more epidermal? So a biopsy is the definitive way. I do try to avoid biopsies because they will leave a scar. Anyone who tells you a biopsy is not going to leave a scar is not keeping it 100. But if we do need to do that, we've got that in our toolkit.
I'm curious if you have a lupus diagnosis, if most of these things are covered by insurance. That's been a challenge I know with some other treatments. And so I was just curious, especially ones that might seem more appearance based, right? If insurance usually covers those, if you're having hair loss or you're having you mentioned Botox and things for scarring, are those going to be usually covered, or is that going to be an out-of-pocket expense?
I think it depends on your insurance. And I participate with a number of different types of insurances, and I'm always happy to do the work and advocate. But for example, you think of a patient, I just had a patient who with discoid lupus, a scarring alopecia. We were able to get her wig covered because we used the proper diagnosis and the proper turn of cranial prosthesis. So there's ways to work with the system. I did have a patient, this was at UCLA, who had a type of lupus that caused atrophy of the muscle. We were able, through a program, to get her dermal filler covered. So what would have been a $2,000 treatment, I think she paid cost of goods. And I think, honestly, as a dermatologist, I'm willing to work with any situation. Am I gonna give you free Botox, girl? No, I wish. But, depending on what the situation is, we may be able to do a lot with a little. If they're treating one scar area, that might be 2 to 4 injections, which can easily be less than $150. And I make those exceptions for my medical patients.
Hi, I was just wondering what kind of ingredients to avoid in a sunscreen.
Yeah, I would say ingredients not necessarily to avoid, but again, if you have something that says avobenzone, benzene, those are not going to be the full coverage. Now, something's better than nothing, again, especially, that covers the top epidermis. But when we're treating inflammatory conditions, we really want to make sure it's mineral-based. One thing to look out for is if it doesn't call itself a sunscreen. If it's calling itself a sun mist or a sun tint, that's because they didn't do the work to get it labeled legally as a sunscreen. So do be on the lookout for that marketing ploy.
I have a couple of questions. First off, what do you think of red light therapy?
I like red light therapy overall. We've done a lot of research that shows that it helps not only the skin, but there was a trial with post-COVID, long COVID syndrome, and those patients were exposed to red light, and it really helped on a molecular level and a clinical level. Patients with lupus, patients with melasma need to be careful because the red light, depending on how you apply it, especially with the mask, that heat can cause that inflammation and trigger those T cells to start partying. So we definitely want to be mindful of how you expose yourself to red light. There's not enough data to say I definitely recommend it. I'm actually attending our dermatology conference. We have an annual one every year, so I'm looked to so that I can stay up on to date with the literature. So that's one area that's really a hot topic right now. But I would say try it. And make sure that you're using a lamp or a light that's a little distance from the face so you're not feeling that heat. And tell me, you got my email, text me. I kind of want to, you can see my number, you just can't see my Instagram. Text me.
And also, when I started the Plaquenil, I noticed a little bit of a hyperpigmentation, a little bit of a darker color, and then it came around here, and then eventually, I'm sure nobody else noticed it, but I'm a tad darker all the time. I used to be really, really, really white.
Yeah.
So, but I don't know if that was the Plaquenil or could it be the lupus?
Hyperpigmentation is a known side effect of Plaquenil, and I always counsel my patients on that when we do prescribe it, with the importance of that strict protection. Because
Okay. And do you take Medi-Cal?
I am not yet participating with Medi-Cal, but I submitted my application like 6 months ago. Like, I don't know what they're waiting for at this point. But we do offer a discount for Medi-Cal patients. So instead of the average consult fee, it's $175.
Hi, thank you, Dr. Zoe. Just a quick question. Do you have a preference with either, like, because you said a mist spray, or like a spray versus like a powder versus like a cream?
I like a cream because it goes on evenly. I've seen people do the powders and you almost always miss a spot. I personally find it tough to put around my eye, and that's my trouble area. With the sprays, again, you can miss, and you can probably go on TikTok and see people who like sprayed on sunscreen and then they have a tan all around the areas that missed the spray. So if you are going to spray, do it close and make sure it's fully covered. But for me, the most important thing, do something that you like, do something that you're going to be able to reapply every 2 hours and that you're going to be able to build into your routine. That's why I didn't make my talk too long. I know you guys have plenty of questions for me.
Hi, so as we've learned today, mineral sunscreen is a medication. Why do you think it's not covered by insurance then?
I'm so glad you asked that.
Since we need to reapply it every 2 hours.
Yeah, I'm so glad you asked that. So it actually is covered by FSA and HSA plans. I will often tell my patients to utilize that, but it does depend on your insurance. Like part of my UCLA residency, we trained at the VA, the Veteran Affairs Hospital, and it was covered by their insurance plan. So I would challenge you to look into your insurance plan because it may actually be covered if you are getting it through a dermatologist's office or if you have a certain medical diagnosis.
I have a question in regards to taking vitamins, like anti-inflammatory vitamins like zinc, taking zinc or taking like turmeric or taking like things that help with anti-inflammatory of the scalp. How does that help in regards to having Decoding lupus?
Some supplements have more data than others. Zinc, for example, well established to help with wound healing. I will often recommend zinc to my patients. It's a part of my protocol to treat not only lupus, but also other inflammatory conditions like HS and even acne. Vitamin D, a supplement, a hormone that also shows anti-inflammatory properties. Vitamin B, most likely to cause acne, but has its role in certain cases, but in inflammatory prone skin, it's not my favorite one to recommend. So I think it all depends, you know? And I think there's a lot of do-it-yourself at home. Let me take this turmeric and just put it on my face. Like, do you even know if that's real turmeric? What's the concentration of the turmeric? And now you're in my office for a chemical burn. So I say everything with moderation and research, but there's absolutely a role for supplements like magnesium, even ashwagandha for helping with stress overall and stress-related hair loss. So happy to talk more about those offline. Again, you guys all have my number at this point, so shoot us a text message.
Thank you so much.
Oh, do you want to? We'll take one.
Last question. Thanks so much for hanging on with us.
Hi, it's been only 1 week since I started taking the medication, and I don't know if I can ask because I simply don't know side effects, but my nose inside always burns, and like I have flakes inside my nose, and I don't know what is this. And also tons of cystic acne.
Which medication, if I may ask? If you care to share.
Benequil?
The Plaquenil?
Plaquenil.
Yeah, I mean, Plaquenil can definitely cause some sort of psoriatic-like features. It's a well-known side effect. So I would say talk to your physician about making sure you're on the right dose. Again, patients don't read textbooks, so just because it says to start at 400 milligrams a day, maybe based on that study was done on a 200-pound white guy, maybe you need to start a little bit lower and titrate up. So I would definitely share those symptoms with your doctor, use these tools to make sure that you're advocating for yourself and they're hearing you, and there's always another solution.
So I think we're going to wrap that up, but obviously you do have all the information up there. Like Dr. Zoe said, feel free to send any other additional questions and thoughts, and I'm sure she'd be happy to get back to you. Thank you so much.
Hi, Mom.
Thank you. Okay. Okay, that was awesome. So for our final session, thank you. I lost my word. You knew that. You knew it. We are going to have our Lupus LA patient advocacy panel, and as we're going to kind of do it more of like a round table with Q&A. We're going to walk around with the microphones. And Susan, do we know, is everyone going to be sitting up here? Okay. All right, so we're going to get some chairs going. Thank you. Oh yeah, we can put it in front here. We can put it right in front if you want. You want to go on the, or? Yeah, on the stage. Oh, on the stage. And then here's another one. 4?
We are now 4.
Now 4, all right.
Thank you. We're going to give these ladies a couple of mics to share. I just want to sort of share with everybody that that the ladies that are sitting on this panel, we have two women that are not. I'll use this. 2 ladies that aren't able to join us today. So this Lupus LA Patient Advocacy Panel was established to ensure that a diverse group of patients have a voice. And at the past few conferences, we've covered a couple of topics, and the ladies took questions at the end. Today, we'd like to create more of a roundtable. So as Maggie shared, we have a couple of microphones around the room. Please raise your hand. There's enough staff to come to you. And today, we're going to focus on the challenges of showing up, both for your personal and professional commitments, and how you manage when you can't show up, and how you manage when you don't feel 100%. So an example was, last week I spoke to a patient who is a student, and she mentioned to me that she goes to class on Monday, feels great, Tuesday feels great, and then Wednesday can't get out of bed. She has a really hard time explaining that, not just to her other, the students in her class, but to her professors. So let's talk about your experiences and some suggestions on how you handled situations when you couldn't show up. You all have their bios in your folders, but I will ask that you share your name and what you do before you sort of take part in this question. So why don't we start with you, Lorena?
Hi, good afternoon, everyone. My name is Lorena Gordon. I was diagnosed with lupus at the age of 13. And I've been very passionate to be a voice and be able to share my experience, just because I know that that's something that could have helped me when I was recently diagnosed. I'm a filmmaker, and I use my art to be able to also showcase lupus and other diseases that we don't really get to see a lot on screen.
So Lorena, why don't we start right here while you're chatting? Just an experience where maybe you couldn't show up for something, and how you handled that. Certainly in your field, you have to be on every day. How do you handle when you're not feeling that well?
Yeah, just today alone, I've been working all week, and usually I'll have 2 days off, but this week, because I wanted it to be here, I worked, like a whole week straight, and I wanted to be here earlier, but I knew that I had to rest and recoup, if you will. So it's really knowing your body and knowing your limitations. I know that if I were to push myself, that I would be feeling the effects of that, and it's being honest with yourself. I think that's very hard, or at least for me, to do, because I want to do everything and I want to go to everything. But I know that I can't, and I just have to kind of, give myself grace and do what I can.
Kelly, you want to share a little bit as well?
Yeah. Hi, I'm Kelly. I am a mom of 2 little ones, age 4 and almost 3. And I have my PhD in pharmaceutical science. I would definitely second that. I think also communication. So if it's whether it's your employer or your family, friend, communicating how you're feeling and taking into consideration, whether or not you should go to an event or participate in an activity, knowing that, okay, how is this going to impact me later? Am I going to be flaring tomorrow if I go out tonight for mom's night or with friends? Same thing with work, like communicating with your boss and your employer, like I need a 10 to 15 minute break. I need to go get some water. I need to sit down, making sure that you're advocating for yourself.
Sharon?
Hi everyone, my name is Sharon Singh. I was diagnosed with lupus when I was 14, so it's been about 11 years living with lupus. I'm a current healthcare worker. I'm pursuing graduate medical education to become a healthcare provider, hopefully in the future. And working in medicine is often very difficult, as anyone can assume. So having lupus and having to show up consistently, not only just for me, but for my patients, I think one of the biggest things that's important is communication and getting accommodations. And sometimes that's difficult with lupus because a lot of people don't really understand what lupus consists of and how severe it could really be. So for me, I always advocate for myself. I educate others, and I always allow my peers, faculty, and people who work with me to learn from me. So anytime I am having a flare, if you could visibly see it, like any redness or even my Raynaud's right now, I will try my best to educate people. And sometimes they'll understand, sometimes they don't, but that's the best that we can do. And I try my best to be consistent, and yeah.
Vanya?
Hi, everyone. My name is Vanya. I was diagnosed at the age of 10. I've known Lupus LA now since that early diagnosis. I was in remission at the age of 13, and I was asked to speak by my doctor about my story. I was very adamant not to because I did not want anyone to know what I was going through. But since then, I've been very passionate. I saw the outpour of how much impact that made, this little girl's story, that I was in an induced coma for a week. I lost my complete memory. When I awoke, I was told I had lupus and was asked, do you know who this woman next to you is? I did not know her. She was my mother. At the age of 10, I had to relearn everything, including living with lupus. And I've been very passionate to help those other children going through that, because just along with these ladies, I felt alone. I felt I was the only one in the world going through this. And joining support groups and joining these conferences, I saw the other faces that my doctor was talking about, that I wasn't the only one. And definitely growing up with lupus, I had a mom that was very advocate. She would very stomp on those teachers' feet that would say, she's just lazy. She's just not trying. Why is she always absent? She was like, the heck my daughter is lazy. The heck that she's not trying. She's got 6 appointments, therapies, on top of that, and she has a bunch of medicine and treatment to go through. She's not lazy. From then, I had to learn how to advocate for myself. Growing up and going to the job field, I was very transparent with the employers. I said, my name is Vanya, I have lupus, this is part of the package that you're gonna get. I showed very early on that I am hardworking. So when those days did come, when I was sick or couldn't make it physically, emotionally, mentally, whatever that was, they could see she's not lazy, she's not faking it. When she is feeling well, she does give her 100%, and they see that. But I was very transparent. I wasn't just gonna talk about it once it was bad and sick for a whole week. So they didn't see that I was keeping this under the rug kind of thing. I was being upfront. I felt like that very much helped, even though it is sensitive and hard to talk about. It's important that they know, because then also they're able to accommodate. Maybe at times I couldn't work the 8-hour shift, but they would work with me to work the 6-hour or the 4-hour shift that I could do. And they were more adamant to work with me. And a lot of times I have found when I am transparent, people are accommodating and are understanding. Like, oh, I have heard of this. Oh, I have a neighbor. Oh, I have a friend who has fibromyalgia. Oh, I've heard of arthritis. So they are more willing to work with you when you are transparent, as hard as it may be.
Thank you, Vanya. Anybody in the room have an experience of not being able to show up and how they manage that?
No, I have a different question. When I finally made it, I went back to school in my late 40s and made it through the Cancer Information Management program. And the exam, my instructors or the director of the program gave me extra time to finish the program. But then the first 2 jobs that I applied for, and I won't say where they were, but one of them, or on the application, they both asked if you had lupus, right? And they asked, because they were at hospitals, and they asked, you have to provide a lot of medical information. And, I just think that if I hear what you're saying, but it actually worked against me. I got the first job that I applied to, but it worked against me, especially because my thinking was not as quick as it needed to be. And so, I actually resigned.
Yeah, so this is a consistent problem in just medicine in general of if you do provide all your medical information, it can be used against you. I've seen it myself. I've experienced it myself trying to pursue medicine. And unfortunately, it's intuition-based. Like, you have to find a company or an employer or a school that's willing to accommodate you. And that is unfortunate because there are laws in place that are supposed to protect people with disabilities. Unfortunately, a lot of the times, people with disabilities are not protected. It's used against them. I've experienced it myself. Some people label it as disability discrimination, and it's rough. So in cases like that, that's correct. Yeah. So that is a pressing issue in today's world, and I really hope one day that we're able to fight against that, advocate for ourselves, and hopefully come up with a better solution. But as of right now, the solution is either to be accommodated properly by a school or a employer, or you're not and you're forced to leave. And it's very hurtful, it's very unfortunate, and I empathize with you. And it's unfortunately just the world that we live in today. And so what we can do is, I'm trying to pursue a career in medicine to hopefully be that change, to hopefully one day if somebody's working under me or if I'm working with somebody, to provide them with proper accommodations and to understand them. But yes, it definitely can be used against you, sadly.
Hi, I'm Elizabeth. So basically, I recently went back to school and I thought I could do it. I was like, I'm ready. And then my migraines didn't let me. My joint pain didn't let me. My fibromyalgia was flaring up every time I was carrying my backpack. I was dizzy. My brain fog didn't let me concentrate. And then I was expected, it was a biology class, so I was expected to do a lot. And I couldn't do it, and I had to drop the class. And it was very hard for me because I'm European, so hard work is very important, and laziness doesn't exist. So I keep trying to like go back to school and complete like just a bachelor's, but it feels impossible like showing up every single day, even twice a week. It's like, but I know some of you guys have gone to school and have finished school, but how do you do it? Because for me, it seems like impossible right now.
Yeah, so I have my PhD, so I went to graduate school at UC Irvine, and my very first quarter there, I had to take medical leave. I was too sick to go. I had to get special approval from the entire faculty. It felt embarrassing, and I felt like a failure at that time. But taking that break was the best thing for myself. I was able to take the medications I needed, rest, and try to get better. I didn't go back to school in a remission state by any means. I'm definitely someone that will like push through the pain, which I don't advise at all. But just know that you can do it and keep telling yourself that, because I believe that mentally you telling yourself that makes a huge difference. I think you also need to communicate with your teachers, with the school, with the disability center, see if you can get accommodations for taking tests, for taking breaks. They should work with you. We were actually talking a lot about this earlier, that there needs to be some changes at disability centers, at schools. Professors need to be more educated on how to help students so that they can get the degrees that you deserve, right? So I think communicating is like so important, because I had to advocate a lot for myself to get the help and the accommodations I needed, but it ultimately helped me get my PhD.
Yeah, I just wanted to say thank you all, because you all are amazing, strong warriors. And I always tell people like it's so important to figure out how to thrive in life in spite of having lupus. And like for me, just like you all, I decided on, sometimes I can't show up at all. And a lot of lupus warriors have asked me like, how do you work and then also have lupus? I started fighting for paid leave policies, and like California here, you guys are one of the first states to come with paid family leave, because a lot of lupus warriors, we can't go to work and we end up having financial burdens and things like that. So I feel like getting involved in policy change and fighting for paid leave is a great thing, but also sharing your stories and helping other people feel like they're not alone is an amazing thing. So thank you for always helping other people know that they're not alone too.
Thank you. Sorry. Okay, so hustle culture is a very real thing, even though I feel like it's dying down, but it's, there's still a lot of pressure from it. So I'm curious to learn what hustle culture has looked like in your respective fields and how you've navigated those pressures. Yes.
Yeah, I think that goes back again to like being honest with yourself and communicate, with the people around you. I think there's always that, just that hustle culture mentality that you just have to do everything all the time. But like I said, like I know
just because my body tells me. So my body will tell me, right? So now I know that I can't push myself the extra, mile that I want to do. I want to, but I can't. So I think also letting the people around you, whether it's family or coworkers, also know, I think then they understand and can even be an advocate for you as well, right? In whatever field or whatever situation it may be. But I think it's finding that balance. It's a really it's finding that balance in your life and everything in your life. And I think at the end of the day, it's only going to affect you. So you're the one that has to look out for yourself.
Hi. I have so many questions, and my first one is I'm a mom of 3 boys. They are 8, 5, 3, and in the past year, our lives changed tremendously because from a hyperactive mom who would go surfing with them, skiing, travel every 3 months, be present at their hockey games and practices, I turned into an always tired, sometimes anxious mom with a short-term memory loss and vision loss. Sometimes I'm so tired, I faint, and I don't have control over my tiredness. Like today, I woke up at 7 to be here at 9, but I woke up at 7, I had some water, I sat down on the couch, and I fell asleep until 12. And I just, I'm in shock because there's nothing I can do with this tiredness, and I'm not able to drop off all 3 kids in the morning, for their school drop-offs, or sometimes I'm not able to pick them up because I simply cannot wake up. What would be they're probably not right or wrong steps, but what would be the most honest conversation to have with the 3 young children to explain what's going on with the most important person in their lives at this moment? Because they're not little, they kind of see everything and understand everything. But right now, I keep telling them that Mama got a virus, and it's called a butterfly virus, and sometimes I fly, and sometimes I sleep. And they're like, okay, Mom, but when are we going to fly to Costa Rica for surfing? And I'm like, dude, let's wait a little bit. Mama needs to, Mama's butterfly need a break. And they're like, all right, great, but when?
I relate to this so much. Being a mom is the hardest job in the world, and I empathize with you a lot because I feel like I go through the same thing daily, right? I have a 4-year-old, a fresh 4-year-old, and then an almost 3-year-old, and every day I'm exhausted. My caffeine intake is so unhealthy. But, we push through because we're moms, right? We have no choice. I guess my biggest advice, there is no right answer, right? If you have support in any way, family, friends that can help you, I would definitely communicate to them what you need. If you need them to help watch your kids or be with you in case you fall asleep, or if you're at fall risk, anything like that, I would recommend that. But also in terms of teaching your kids about the illness, there are books, children's books out there. I think there's a lack of books on this topic, but for different diseases and chronic illnesses, there are some children's books that exist. And for me, I started to buy some of these books. My kids are much younger, but even my 2-year-old, she notices, oh, Mommy, why are you wearing something on your wrist? Or she'll say, Mommy doesn't feel well today. And it breaks my heart every time because you don't want your kids to really know that you're sick, right? But I've decided personally to tell them, Mommy has lupus. It's a chronic illness. I don't feel well today. I need to lay low. And of course, they're not always going to understand at these young ages, but I think it's important to communicate to them as well, so they're aware, You know, mommy wants to be with you right now. I want to give you my full attention and all my energy, but I just can't. And I think that's one of the most heartbreaking things being a mom with lupus, is not being able to give your kids 100% all of the time.
Hi, I am Vania's father, and I know the condition of Vania, but I got a really maybe weird question. I know Vania, how we're dealing with lupus for so many years, and I know how it looks now. I got question for all 3, 4, and the rest. You still in remission, or you still acting in your lupus?
I would say, I don't know, recently I felt like my joints have been flaring more than usual, but that could be, again, the pushing myself and wanting to do everything. Overall, I would say remission, according to my rheumatologist. But I mean, it's during this time of the year too, I've noticed that the joints do affect me more than usual. Like just the other day, I couldn't walk on my left foot. So yes, in remission, kind of, but still, you know, I feel the impact of it in my daily life.
I would say my disease is mildly active right now. I wouldn't say it's quite remission because I'm still having symptoms, but I did take like a medical withdrawal leave from graduate school because of my lupus. And because my stress levels went down, my disease activity went down. So I usually live with minimal symptoms unless I do something to trigger my lupus. And fortunately, I do know my triggers, so that's very helpful for me to plan ahead and manage my symptoms.
My disease, I would also say, is mildly active. I've changed my medicine regimen recently, so I'm doing better than I was, but it's very up and down for me. Every day is different. I have pretty bad side effects from an injection medicine that I take, and also the joint pain with the weather lately. Oh my gosh, so bad. So yeah, mine's kind of, yeah, I'm definitely not in a remission state. It's kind of up and down and all over.
There we go. I know you all spoke about, you know, being upfront with employers and school about your diagnosis, which I think is really great. But and I was only recently diagnosed, but I have found that even explaining it, people don't. It's invisible, so they're still not understanding, right? And I don't know if you have any tips for that. It's like, you know, they just don't get it because you don't necessarily look different, or you don't, you know, to them, you don't seem sick, but you feel awful all the time, right? So I just don't know if there's any of you or anyone has any advice for that, because like, you can't just keep saying over and over, like it's exhausting to say that. And then I think the other piece, again, I don't know if it's you folks or folks in the audience, but I think like dating is already hard, but dating with a chronic illness is like incredibly difficult because again, people don't understand. So I don't know if anyone had any tips or thoughts on that.
I'll speak to the first one. I would get HR involved personally. They're supposed to be on your side, right? That's literally their job. So instead of going to your boss, if you feel like it's not working, I would just go straight to HR and explain to them what conversations you've already had, and then see if they can help you get the accommodations you need. And hopefully that works out. Otherwise, maybe it's not the best workplace, which isn't really an answer, right? It's not, around you?
Sorry. Yes, HR, yes, I have accommodation. So thank you for that in HR and my boss. But when you are in a leadership position and you are, you know, there's still a lot of people, right? I still have 50 people that are that I'm supporting, right, as a leader. So I think it's more that piece, and like, I don't know, I guess just educating and continuing to, I don't know, just invisibility is really hard.
Yeah, I agree. I know, well, right now I'm mostly a stay-at-home mom, but when I was working, I made my coworkers my best friends in case, you need anything, any extra favors. They were there for me. Someone I felt comfortable confiding in for everything. But no, I empathize, especially when you're a leader. It's like you don't probably have as much support as you need.
Lorena, can you speak to that? I mean, you're a leader on a set. You certainly have a whole crew working for you and you're directing. How do you manage that?
Yeah, I empathize as well, and I would say to really step into your power. I think that's the way that I've managed to do it, is really step into my power and educate. At the end of the day, it's not all of me, but it's a part of me. So, especially when you're with your collaborators and the people that you're working with, I mean, it's good to be honest with them, so they know your limitations and you can be transparent with them, and they know how you can work. And I think that's the only way that I've been able to, and I tend to work with the same people, so they already know and have that shorthand. But I think the way that I was able to get comfortable with it, at least, was to like step into my power of like, okay, this is a part of me, and this is how I have to modify the way that I work and the hours that I work. And I think people lean into that, or at least actors, when they see that you're being vulnerable, because that's very vulnerable to do, then they appreciate that, and so do the people around you.
Vanya, you work with teenagers. What happens when you're, do you share anything with them, or?
So yes, I have over 10 years experience working with disabled children, and just recently, the last year, I've worked with now middle schoolers. So that's already fun. And I work with disabled, not physically disabled, but they are a bit backtracked in education. I have openly told them that Miss Vanya does sometimes need to be out, or sometimes why Miss Vanya is not going to be as patient today with your attitude or whatever. But I feel like they do also sympathize, because I do remind them that I was once their age. So even just being vulnerable and talking to them about it, that Miss Vanya has been picked on just like you have. Yes, I have had a crush and he didn't talk to me, kind of thing. And like, I am human, and I am gonna have my days just as you are. And and also with my boss, like, I would tell her, like, I'm not feeling well today. She's like, okay, I'll take these over here that are more troublesome today. You can handle them some other day when you are feeling a little bit better, or you didn't get enough sleep. And it definitely helps to communicate, and most people, again, will understand. And some great advice, that if your boss or your community at work is not supportive or understanding, that might be a sign that's not the right place or environment. Because I have found, even if the money is great, your health is number one. Because without your health, we're just sitting at home, miserable, mentally, physically, and it's not worth it. So definitely find the right place, right environment. It makes a world of a difference.
We have a comment online.
Yeah, we are definitely getting some feedback, and what you're all discussing and sharing really seems to resonate with everyone who's tuning in as well. And a few takeaways from someone's shared story is that, also dealing from it from a young age. So I think that, resonates with her, but also the time it takes to not only learn how your body is going to respond, because each person is so individual, right, and unique. Their experience is unique in that way. She felt it's also important to share that it took her a while just to even accept her diagnosis and what those limitations actually are or were, because we have to kind of come to our own realizations, right, first, before we can then ask for help, right? And so she also mentioned that, she definitely is a big proponent of having a team, your rheumatologist, other specialties, and she's had to learn that over time. But she definitely, her at the end, she wraps up by saying, you really do have to be your own advocate above all, which I think everyone is sharing here and sharing their ideas, which is wonderful. And every lupus patient is different. But what's really unique about what we're doing here is that, yeah, we're all individuals, but there is some shared experiences, and there is a lot of value that we can take away from each other. So she just wanted to share that. Anyone want to maybe speak to that, or?
I did want to make a comment about a question about dating. I just recently got married, but I did find that dating was very hard. And once again, even just like I learned at a young age to be very open and honest with my employer about my disease, I also did with my partner. A lot of times, even growing up young with it, I was very advocating for myself. So I would tell my partners that this was part of Vanya and part of my life. I will have to not go down some dates because I have a doctor's appointment, or no, I can't be up till midnight partying or going here or there because I'm tired by 8 p.m. like a grandma. Like, that's just part of me. If you want to come see me, let's watch Disney Plus at home, that's my date. Some, of course, would be like, yeah, no problem. And then as soon as it got down to it, the real stuff, then he was complaining about it. Then I learned it's not me. I was honest. I was vocal about it. That's not the person for me. Yeah, it's easier said than done, but being vulnerable and honest is important in any relationship. The man that I married now, I told him up front, and he has even come to these conferences. He's come to support groups. He even did an interview with Lupus LA about dating me. And he learned, and he also lives with a chronic disease, which I think helped. He has diabetes at a very young age, and he knows the ups and downs of living with a disease that can change your life. And so we are both very susceptible and patient with each other. When his sugar is not well or he can't be out eating ice cream and stuff, I'm just as accepting and acceptable that we can't be eating like this or out that late or whatever it may be. But it's just important to know it's not you. The right person shall come, and the right person will understand and not use that against you as well. Because you are not a package that is broken or anything. You are made just the way you're supposed to be. So please give yourself grace. Of course, that's easier said than done. It took me many years as a child to accept that.
Hi, how you guys doing? My name is Giovanni. So my wife just recently got diagnosed with lupus, right? And at the beginning of our relationship, everything was fine, and until we didn't know what was going on with her. She got a lot of GI issues. She got a lot of problems. None of the doctors could tell us what was going on with her, right? And this was literally a couple months, or if I'm right, a month after we just got married. All the problems that start happening, right? So we passed from a regular relationship to be just me taking care of her, right? In the beginning, it's a little bit hard because I'm a United States Marine veteran, so I was in charge of a lot of people, and I was in charge of their life and whatever they do, right? And it was a little bit hard for me to understand that my wife wasn't capable of doing a lot of things. For example, washing the dishes, cleaning the clothes, folding the clothes, or even just swap them up, right? I grabbed all those responsibilities. I started doing everything for her. I started doing laundry, I started cooking, I started cleaning, I started even giving her massage, trying to understand my way to help her out, because sometimes I feel frustrated that she feels bad, or she don't know how to explain it to me how she feels, and it's for me frustrating because I can't do anything, and the only thing I want to do is help her out, is making sure that she's okay, but most of the time it's impossible. because most of the time I just sit here in the bed, just laying down with a cooler pouch in her head, in all her extremities and everything. She suffers a lot for migraines, for the lights, and this is my wife, by the way. So, like she was saying, she had a lot of problems when she went back to school, right? And I feel like teachers sometimes they don't actually understand, or they don't actually care for those who have like actual problems, because sometimes she wasn't understanding very well what the teacher was saying, but the teacher didn't want to repeat or didn't want to teach right. And even though like I have been going with her to college and everything to help her out with the disabilities and accommodations, but that's fault of the university too, because the university didn't say the paperwork to the teacher for the accommodations. So the teacher just was taking like her word, like, yeah, you're sick, okay. But like when it comes for like homework, test and everything, he didn't want to like actually like help or like, accommodate it, and that was the main reason why she just like gotta leave the class. But for me, it's just I just need an advice. What I can do to help her out more, or what I can do to understand her more.
So you're here to learn and listen and have these conversations. She's very lucky to have you stepping in and doing that, but you're listening, and it's beautiful. So Kelly, you're a married lady. I'll let you share.
Yeah, I second that. You're an amazing husband. You're doing a great job. My husband is very healthy and doesn't understand lupus, right? So I know, I can imagine it's very hard to relate when you're not in her body, right? Just like we all have our own symptoms and we all go through our own experiences. I know my husband has read some books on lupus to try to better understand how he can help. And there are support groups for that too, for like caregivers and caretakers that are helpful. But speaking for school and the accommodations, I've been through that too. It's very frustrating. I feel like schools need a lot more education on how to help those with disabilities, especially in the education space. I've experienced a professor that literally wouldn't give me accommodations that were given to me by the Disability Center because he thought it was unfair to the rest of the class. So I feel you and I empathize a lot on that. Just keep fighting, keep advocating the best you can. Make sure that, the Disability Center, put them in charge if the professor isn't listening and say, I need these accommodations, they're not being met. I'm not sure if there's someone higher up you could even go to. Make sure you're talking to the head person at the Disability Center too. And I would just keep trying to advocate for yourself. See if there's even online classes maybe, so you don't have to be there in person, if you can do anything online, or if there's lectures that are recorded, maybe you can watch them later if you forget things. They should accommodate you, and I'm really sorry that they're not doing a good job, because I've been there.
And I'll also encourage you, we have, a huge YouTube page. We do these live with expert talks, and we have over 100 talks, really just getting an understanding of the disease and sort of what your wife is dealing with. And we've interviewed couples, and as Vanya said, her and her, I think it was your then fiance, I don't know if you were married. Yeah. They were interviewed together on our podcast, and there are couples that share stories about how it's difficult or what it's like to be a companion. So we have resources, other organizations do. So I would say, very much like being here, continue to learn.
Can I just add something?
Please.
I want to applaud you because you're an amazing partner.
Yes.
And And I would say what you can do is ask, right? What can I do to help you? What do you need right now? I think it sounds really silly, but she can tell you, this is what I need help with, or can you help me with this? That's another way too. It's just asking, right?
I think also someone else shared online that really kind of ties into all this is, realizing that we can show up and ask the questions, but that it's chronic and that it's ongoing. So we may be able to help one day with something, but it may not necessarily work another time, but being present and showing up really is kind of the overarching theme of it. But someone else made a comment like it's just chronic in all caps, meaning like this is ongoing. So it's kind of up and down, right? Kind of like a roller coaster. Mental health obviously ties into that, not only for yourselves as patients, but also for family members and doing it together too. I think that also is something maybe anyone can speak to up there as far as getting some other, outside help too.
Does anybody in the room have anything to say? Does anybody want to add anything? Ladies?
I did want to speak on this. I think that getting mental health help is so important, especially living with lupus and any other chronic disease. It's very mentally draining, and you have to almost grieve your old life. Like before your diagnosis, I know before I was diagnosed with lupus, I was a gymnast. I was halfway to the Olympic level. I was a level 5 gymnast. There's 10 levels of gymnastics. And I had to give that up because of my diagnosis, my joint pain. And it's almost like I lost my identity. And so for me, becoming an adult and growing up, I really felt like getting the right mental health resources really, really helped me navigate this new world. And doing more than just talk therapy for me is what helped me, like somatic therapy. A lot of us feel stress when we are flared, and then on top of that, we get more pain. And it's like a connection, a mind-body connection, which is something that I hope to integrate into my future practice as a healthcare provider, of integrating the mental health aspects to make sure that your body is able to relax during times when you're flared. Otherwise, you're experiencing a lot more pain. So I think that therapy is a very, very powerful resource and tool to help us cope with this new life that we're given.
I'd also like to speak on that. I know a lot of us with lupus, we have to grieve our old life and we have to give ourselves grace. But I think as a partner, you too need to give yourself grace. You being there for her, even being here and trying, speaks a lot to your support. I know my mother had a lot of problems, like feeling so bad. She told me that she wished that she could take my disease from me and put that on her back and just let that weight off of me. Unfortunately, she could not. What she could do was go get me my cup of water. What she could get me was my heating pad. That speaks a lot to us. I know it may not seem like you're doing much. You're just leaning over, getting her water bottle. You're leaning over, getting her heating pad or swapping something. But that means a lot. So please give yourself some grace. You are being there for her. You are getting her the cup of water so she doesn't have to lean over. It's a lot for us. It may not seem much to you, but it is. It's a lot.
Yeah, I want to shout out my mom and my brother because they're always there, and I try to communicate as best as I can. When I need extra help from them, and they're always there. And I don't know if it would be helpful if they can speak on, as a family member with the sister or daughter dealing with lupus.
All right, you ready, Lorena? She can be a real pain. Literally and figuratively. No. I think over the years, we've garnered like a form of communication to where I can see and I can feel when she's not at her 100% before she even asks for anything or showing any signs. But then again, collectively we can get blindsided too, because she's not expecting pain or joint or something, not feeling well, and then all of a sudden everything just kind of falls apart in terms of like either the day or her plans or whatever. So then we have to like quickly pivot to seeing what she needs help with, if anything, or if she needs to just rest, or if we need to like push her to just pull the plug for the day, for the evening. Let's not go for the walk. Let's not go to the gym today. Let's just recover. Let's call it a recovery day. And she hates that. But I think it's the truth. I think it's needed. Let's watch a movie today. Let's stay in. I think just that little push, I think, and like push/support that maybe she wants to push herself to do more, but we have to kind of reel it in sometimes. And then she'll let us know too when she's not up for it. And when she's not up for it, it's a shocker, but I'm happy to hear that. So just kind of be all ears, be on guard. Just be you. You'll figure it out. It's been like over a decade, so it's a long time. And for you, it's been a couple, maybe a year or two, something. 6 months, something. No. 7. Okay, yeah. So I mean, it's a journey. It's not a destination. It's going to be a journey for sure. So we're still figuring it out. Who knows? And then there's like different stages of life too. Elementary school, junior high school, college, career, professional life, private life. It's a lot. Just be open-hearted, open-minded. I'm a musician, so open-eared as well. And yeah.
There's a lot of love in this room and in this community. I'm always learning something. And we want to thank you ladies for being here. We want to thank all of you for being here and for being open and participating. We appreciate it. We learn something from you all the time. So we're going to do our giveaway. We're going to have you ladies help out. We're going to pick some numbers. And thank you again for coming.
Thank you, everyone.
Okay, so now's the time to find those blue tickets that you were given when you first came in. Let's see who our lucky winners are going to be. Get your tickets.
All right. So it's our fault if you don't get paid?
3 of them. So only 3 of you get to play.
Okay, we're going to read the first number.
Yes, it's 730101. Congratulations.
One of you, it's only going to be one of them.
All right. The second winner is 730105.
You do it. Okay. Woo. Okay. Do you want to read it? Sure. 730080.
I also want to just remind everybody on your way out, there's a survey in your folders. We also have a QR code. You can do it at home. I think Maggie explained earlier that we're working on an interactive tool we're creating for newly diagnosed patients called the Roadmap to Lupus. And in this phase of it, it is all research. We're looking for patients, both newly diagnosed and patients that have had lupus at all different parts of the road, of the journey, to sort of offer their feedback. Our doctors are also doing that. So please know that when you participate, it really will make a difference in the content that we create. So we encourage you to scan the QR code, do it at home, do it here, however you'd like. Thanks again, everybody. Have a great weekend.